Hi, good morning or good afternoon, everyone. Thank you so much for joining this conference, especially on a Saturday. So we're going to go ahead and get started. So again, thank you all for joining, and thank you for all of those who joined also on time during the registration. Really appreciate it. So just as an introduction, this conference is one of the conferences that is geared towards the Region 3 students for PsychSIGN, and that includes New Jersey, Delaware, Washington, D.C., Maryland, as well as the state of Pennsylvania. So this year has been a great year for PsychSIGN, despite everything that's going on in the world. Overall, we were able to schedule a lot of conferences across all of the regions, and we are very excited for the national conference, which will be coming up. I will be putting the link to register for the national conference in the chat. And if you have any questions at any point, please let us know. So yeah, if you can, please register for the national conference. There's going to be a poster hall. So if you have any new ideas and new research you've been working with, it's a great opportunity to present those. Also, there will be a residency match panel, which would be a great way for us to network with some program directors. So also, this was also a great year for Region 3 specifically. We were able to work on a lot of projects with PsychSIGN regional chapters. And also we were able to work on the big project for this year, which was the PsychSIGN magazine. And thank you for all of those who submitted submissions for the magazine. It's currently in the works of being edited. And hopefully the magazine will be finalized by the conference mid-May, and we'll be able to post it on the PsychSIGN website. And just to go over the agenda for this meeting. So first thing, we're going to have a very exciting diversity in psychiatry panel with Dr. Babajide and Dr. Diaz Garcia. At first, we're going to start with some questions, but please feel free to drop your questions in the chat. You can direct them towards me and I'll be able to read them. And after that, it's going to be followed by a lecture in marijuana and medicine with Dr. Nelson, who is also currently on the chat. That will be at 12. And then that will be at 12:40. And then that will be followed at 1:20 by a lecture given by Dr. Mintz, and it's going to be on psychodynamic psychotherapy in psychiatry. After that, there will be an optional Q&A with Dr. Mintz. If you wish to say, you can ask him questions, and he's very excited to answer all the questions we have about psychodynamic psychotherapy. That Q&A session will be at 2. And then at 2:20, we'll have a session with Dr. Wasser, and it's going to be on leadership and networking in psychiatry. He's an early career psychiatrist who's very excited to share with us tips and tricks on how to be involved in leadership in psychiatry, as well as how to network and how to approach asking for mentorship. And then finally at 3 p.m., we have our Matching in the Virtual Era psychiatry match panel, which will be featuring 3 students who have matched during this past match cycle. And yes, that will also be a Q&A where we can direct questions directly to the students, and they'll be able to answer any questions you had about matching. So thank you for listening to this very long introduction. And right now, we can go ahead and get started at 12 with our first session. And yeah, so please feel free to use the restroom or get a drink or anything in the meantime. And don't forget to direct all questions to me in the chat. One more thing also, I'm not sure if you can see on like the upper left corner, this conference will be recorded and it will hopefully be posted on the PsychSIGN website as a YouTube link. So just so you know, keep that in mind when you're asking questions or asking stuff in the chat. We just want you to be cognizant of that fact. So yeah, thank you so much. And hopefully we can get started in around 5 minutes. Hello again. So I think we can go ahead and get started with our first session. So thank you so much for Dr. Babajide as well as Dr. Diaz Garcia for logging in. And just as a quick introduction, Dr. Babajide is a resident and physician currently attending Rutgers, New Jersey Medical School residency program in psychiatry. He went to Davidson College where he graduated with honors in sociology. While at Davidson, he wrote a thesis on how queer individuals navigate through hip hop culture. He was also the officer of his institution's psychiatric interest group, as well as the president of his institution's SNMA, which is the Student National Medical Association. He's also an active. He's also active in community activist groups, and we are very excited to have him today. Dr. Babajide, did you have anything to add or anything to say to the group?
Okay. Thank you for having me here. I'm excited. Thank you, Chadin, for the introduction.
Oh, we're very excited to have you as well. And Dr. Memphis Diaz Garcia, he's a graduate of anthropology of Brown University. He is a New Jersey Medical School graduate, and he obtained his MD from NJMS. He's also currently a psychiatry resident and intern at Rutgers, New Jersey Medical School Psychiatry Residency Program. His current interests lie in consult liaison psychiatry. Anything to add, Dr. Diaz Garcia?
No, perfect. Thank you. And it's a pleasure being here. It's a pleasure to meet every one of you. Thank you for this opportunity.
Thank you both for logging in on a Saturday morning. Just as a opening up the question, and since this is a panel on identities and diversity of identities in psychiatry, what does the concept of identity mean to each one of you personally?
I mean, to me, at least to me, identity is like all the aspects and qualities that make you a unique person. And it could be whatever you feel is inherent to yourself, or it could be in relation to your social groups and everyone whoever you associate with. It could be in relation to your professional or academic associations as well. All those little things put together, and even like the experiences that come with all those things are what culminate to who you are, or what I feel is my identity in general.
Thank you.
Yeah, I would agree. I feel like identity is something that makes you identifiable. So there's like two ways that I look at it, kind of. An identity is kind of how you see yourself in relation to the rest of the world. So you may identify as something that other people identify you as, or you may identify as something that's discordant with what other people identify you as. And so it kind of, identity is very unique in the way that it kind of informs the way we form relations, and in the way that we interact with our surroundings and operate in the world. So yeah, like like Dr. Diaz Garcia said, it does make us very unique, because our identity is kind of what tailors our experiences.
Thank you for this lovely introduction and definition of the topic. So from now on, I think the questions are going to be a little bit more personal to you. So in terms of your personal identities, how do you feel like you were able to express those while you were attending medical school?
For me, at first, when I started medical school, really expressing my identity was like the last thing in the back in my mind. You know, I was adjusting. I was like, oh my God, who am I? I'm this like new medical student who doesn't know anything and just came from college. I'm meeting new people and I'm in a new environment. But later on, I think it was in medical school that I kind of sort of felt like I was able to go back to getting in touch with who I am, where I come from, my family, and my I guess my identity as a Hispanic male or Dominican male, and really teasing out what it means to be Dominican, what it means to be American. On top of that, teasing out what it means to be a partner, or what it means to be like a father. Okay, so that was my experience in med school. I joined LMSA, and I was part of that. And then the other part of me was also working on my more like public identity, like who am I as a professional? Where do I want to go? What do I want to be? And developing an idea of who would I be as a psychiatrist in the future. So I got kind of sort of more involved in trying to do research and collaborating, reaching out to my attendings and trying to kind of sort of get into that more professional setting, which are things that I kind of sort of wasn't even thinking about before med school.
Yeah. So for me in medical school was kind of rough, but I mean, it's rough for everyone, right? But particularly with my identity, because as you pointed out, I really like to be involved in community activism. And medical school kind of takes your time a lot. And as I stated before, your identity is kind of also what makes you identifiable. So what is coherent to other people? And all throughout medical school, a lot of administration was trying to formulate an identity for me as a physician, right? So, you know, you would hear things like, as a physician, you should do this. As a physician, you should carry yourself in this manner. As a physician, you have to worry about these things, these things, these things. And I guess, professional identity was kind of an affront to some of the things that I wanted to do, specifically as like a queer Black activist, because I was, and also this is the South, this was in Texas, I was to a certain point asked to shroud parts of what I identified as in order to be more palatable in a sphere that I felt like I wanted to work in, which informed the way I was informed my choices basically. So it kind of made me decide and kick out certain specialties and look at other certain specialties more strongly, because I was like, well, where can I be the most free, you know? And so I feel like it was a battle, but like it wasn't like it was its own unique battle, but I always battle with identity when I'm working at institutions or in certain spaces. But that's what medical school was like for me, and I had hypertension throughout, but now I'm good.
Oh, but that sounds very stressful, but thank you for sharing that and letting us know of your experience. So I guess in the process of all this, and I know Dr. Babajide already touched on this a little bit, but so I guess what aspects of your identities does psychiatry speak to you? And how do you feel like that was able to fulfill, but also maybe not fulfill some parts of your identities in terms of activism, being present, celebrating your identities? And that goes to both of you, Dr. Diaz Garcia, as well as Dr. Babajide.
I think in that aspect, I think what I feel that psychiatry really relates to my identity is that you have to be very conscious of who you are internally and have a really strong sense of who you are in yourself. We all talk about, when we learn about psychiatry in medical school, we learn about countertransference and transference, and a lot of being able to identify those aspects of your encounter really relates to how well are you able to be as insightful with who you are internally, and kind of sort of reflect on how the patient is reacting to you and how you're reacting to them. And I think that's kind of sort of how at times, like, I don't always notice it, but there are times that, yes, I have to kind of sort of be more conscious of who I am as a person, how I act, how I speak, my mannerisms, and how that kind of sort of bounces off the other people and those around me. The other aspect of it is, I feel like as psychiatrists or future psychiatrists, especially in the community that we're more involved in Newark, at least, I feel like we have to have a stronger understanding of our community and the identities of the people in our communities and how that affects their everyday lives and their everyday experiences, to really understand how we are able to address their issues, because someone's social struggles are really intertwined with their psychiatric illness and their access to care, and what aspects of their care they feel what aspects of their care needs to be addressed before you can even continue to really being like, but you need to take your psychotropics, you need to take your medications. And that makes sense.
Yeah, it's that's a very good question. And this is PsychSIGN, so I know there are people who are interested in psychiatry. I'm going to be a little bit candid. All of medicine, right, is going to be traumatic to certain people, including psychiatry. And examples, like, we pathologize some things that I personally don't think need to be pathologized. However, psychiatry more has a history of having to be very willing, like Dr. Diaz Garcia said, very willing to address social factors. Because it's almost impossible to talk to a patient and have them not bring up parts of their identity. So while in, like, say, like medicine, surgery, other places, it's a lot easier to just focus on the pathophysiology and focus on whatever pathology that they're coming in for, even though I'm like, we know the field is getting farther, right, with social politics, and more areas are becoming more cognizant of how much that influences a patient's medical care. In psychiatry, when you go to therapy, like, you have to, like, regardless of what your framework is as a psychiatrist and how you navigate in the world, people are coming to you with their own issues and their own identity. So if, you know, you were in the, like, 80s, whatever, where homosexuality was, like, a lot more stigmatized, people are still going to come to you and they're going to be homosexual, and you're going to have to, like, treat them. So you have to be, at the very least, open to discussing all of these things about identity. And so, you know, I've had patients who come to me and say, like, they talk about their transness, they talk about their race, they talk about their poverty, they talk about all of these things, and you can't just ignore it, right? You have to be able to address it. And it's not necessarily I'm saying psychiatry is good or bad or better or worse. I'm just saying, for what drew me is that it's more open, because it kind of forces you not only to self-reflect, but also become more comfortable in addressing a lot of things that other specialties may be uncomfortable addressing. I hope that answered the question.
No, it absolutely did. Thank you so much.
And I also want to add, on top of that, it's a lot of other specialties are really uncomfortable with addressing it. And I see it all the time. Whenever you're on a consult service, they have to call us to that we have to address all these other social issues, things that they believe are psychiatric. A lot of times can sometimes be underlying social issues or issues with communication, which is another major part of our role, is kind of sort of delving into that liaison aspect.
That certainly can be true at times, for sure. So just a reminder, please feel free to drop any questions that you have in the chat. You can direct them towards me specifically, or if you want, after we're done with some questions, we can open up the floor so you can ask questions directly as well. But for now, we're just going to be asking a couple of pre and written questions, and after that, we'd love to hear any questions the group might have. So I guess like as a follow-up question to what you're talking about as a psychiatrist, like Dr. Diaz Garcia mentioned, there's always transference and countertransference. How do you gauge what aspects of your identity you feel comfortable sharing with a patient? And when do you draw the line of I'm okay sharing this with this patient versus I'm not okay sharing certain things with another patient, for example?
I can go first since Dr. Diaz Garcia has been going first all the time. Um, it's very interesting that you bring up this question because I just had students ask the same question while they were on the psychiatric clerkship rotation, because you will often have a patient ask you like a rhetorical question or ask you a question about yourself, and you like people are taken aback by that. And kind of what I told them is, if you feel, or what I do is if I feel it's going to strengthen the relationship, if the patient is on the fringe of like compliance or like trusting me, or if it's going to build rapport, then I will divulge that information. If I think it's also a safety issue, like some people want a psychiatrist that they can feel safe talking about certain things, right? So some patients who are struggling with addiction will want a psychiatrist who's also struggled with addiction, or people want a psychiatrist or a therapist of the same race. Those are things that I'm willing to divulge if it's going to strengthen the bond. One thing that I do constantly tell people to think about is that, you know, they do tell us, especially with therapy, that you're trying as much as possible to be like a blank slate, so that people are not, they don't have too much information about you, like don't show your family, don't do all these things. But that's kind of impossible, right? I can't hide my blackness. I can't hide, for the most part, I can't hide my maleness, right? So that's going to be presented, and you kind of have to decide whether you want that information to be divulged or not. Another technique that I use if I don't want it to be divulged is I ask them why something is important to them, and then like have them tell me like why they asked the question or what's important about that question to them. So it really depends on the situation. But suffice it to say, if it's for like safety or rapport building, I will divulge information.
Yeah, I don't even know if I have much to add to that, but I will say, yeah, I totally agree. A lot of times when I have gotten into situations where patients will ask me things personally, but it really depends on what the situation is. Most of the times, you know, you have to be prepared to know what to answer, when to answer it, whenever, and you have to be kind of sort of have no expectations of your interaction, right? You have to not even expect the worst, not even expect the best, not even expect how they might even relate to you. And I feel that a lot of times, yes, I will try to express things about my identity if I feel it's going to strengthen the relationship with the patient. I feel like in this field, it's compared to most other fields, it's the one field that it's fully dependent on whether your patient is vibing with you or not. And if they don't vibe with you, it's not you. It could be just that you're just not the right one. And developing that rapport is like everything for the care of psychiatric patients. The other thing is that like how I respond again varies. And I agree with Lukman. I do this a lot too, where it's like I'm also like a novice, so I'm an intern. So, but at least with the few months of experience that I have, what I do a lot is like I've gotten the questions of where are you from, what do you do, and it depends. If it's important to ask, well, why is this important to them? Why does it matter to them that they know where I'm from or who I am, or and other patients, like I feel like, especially like if it's like child and adolescent patients, it's just simple curiosities of them being children, and I'll just openly tell them, oh yeah, you know, I'm Hispanic, because it kind of sort of helps me strengthen my interaction with them there. Yeah, it really all depends. And I agree. It's all about trying to develop that alliance with your patient.
One more thing that I will add is that you also should remember that a lot of patients can just look you up anyway. So they can find information that way. So sometimes they'll ask you a question that they already know the answer to.
Yeah, that's that's true. Maybe they're just, it's like that saying that some parents say, it's like, if I'm asking, I already know the answer. Um, so, again, delving deeper into the topic of countertransference. So if a patient projects some aspects of their identity onto you because they find part of you and then they latch onto it, for example, and then they project part of their identity onto you. How does that resonate with you? And how, I mean, not to be like super psych, but how does that make you feel? And what does that, tell you about yourself or the patient in that case?
Oh, we're getting real deep. Okay, cool. So to be honest, so I know we learn, and especially psychoanalytic and psychodynamic therapy, you're supposed to have a poor memory, and you're just supposed to like let things happen. I mean, obviously, to a certain degree, you're guided, like a guidance person, guidance, not counselor, but guidance person. Um, and so that's kind of supposed to happen. They're supposed to, you're kind of trying to get them to, like, what you're trying to eke out of them, the types of ways in which they respond to things out in the real world. So it's kind of like a microcosm of their life, life relations. And so you're expecting them to project, you're expecting them to kind of bring stuff outside in to the sessions so that you can get a better idea of what's going on, but also so that you can have them reflect on that as well too. Like, say, what just happened here? As far as that with us, right? We're all human, we're all fallible beings. Like, to be honest, like, countertransference, how, like, so it depends on what's going on, right? I don't think that yeah, so like there's sometimes where you can hear things that just like super resonate with you, and you kind of like lose yourself as an actual therapist and kind of like, either become empathetic to the patient or empathetic to a patient's victim or empathetic to, like, so it's like, because like I said, you're going to talk to people who've murdered people, you're going to talk to people who've raped, you're going to talk to people who've been victims of rape, like all of these things, right? And you have to kind of remember that, you are not, you have to remember that you're not there to basically tell a patient what's right and what's wrong, especially in therapy. You're there to like help guide the patient, obviously, right, within the sphere of safety. So sometimes you do have to check yourself. I can only give, I kind of don't know. We're actually about to have a class on countertransference, or like a group on countertransference. And to be honest, I will submit that I honestly don't know, except through getting your own therapy, how to deal with your own countertransference. All I can say is that I've experienced it. I've experienced it with several patients, and it's odd because you kind of don't know what to do with it, and so you kind of learn a little bit more about yourself because you go back to your own devices, and so at least I learn a little bit more about me and what's very triggering to me, and maybe even reflect on why it's triggering. But I feel like that's all I can say about that. I apologize.
Thank you so much, for sharing so openly, and for letting us know about your past experiences as well and how that relates to it. I think that truly answers the questions. I feel like very well. So thank you. Dr. Diaz Garcia, anything to add, or anything else that you would like to share?
I mean, I don't really have much to add to that. First of all, like my experience with therapy, with therapy, which is usually experienced in the outpatient setting, or even like in the inpatient setting, I haven't had any experiences yet where I felt like there was any actual countertransference that I know of. So for me, it's kind of hard to tell. I mean, there have been moments where patients will tell me like, you know, like, oh, hey nurse, like, how you doing? Or they think that I'm a tech because I look young. But that's pretty much the extent of my experiences. I think, or it could be that like a lot of times I just like, whenever I go into an interaction, whenever I kind of sort of don't react much to things and I try to keep a blank slate most of the times. So I think I feel like I need a little bit more experience really actually having in-depth conversations about people and about my patients about their lives and how they relate with me. That's pretty much it.
So I think, we delved a lot into the patient side of things. So now moving on to the administrative part of things. So a question that comes up often, when, especially for MS3s or MS4s applying into psychiatry is, I know parts of my identity. How would you suggest approaching revealing those parts of our identities in the process of applying into psychiatry? So, and how would you advise someone who's having trouble deciphering what aspects of the identity should reveal to a coworker, for example?
So you're gonna get varying degrees of advice about this, and I'd like to try and categorize it. So there's gonna be the types of advice that are just like, this is helpful for you to think about, just like if you want to match, like get a job type thing. And then these things are helpful for you to think about if you really do truly care about the environment that you're going to be in, right? So a lot of things that I hear, so I'll tell you what I hear and then I'll tell you what I think. A lot of things that I hear when people say, okay, maybe don't divulge this information. Like there's even rules where they can't specifically ask you certain questions during an interview, like whether you have kids, whether you have a family, things like that, where else you applied, to protect you all. But before they kind of had those rules, or they were just like still kind of tinkering with them, people would be like, hey, don't say these things, right? Because you could possibly ruin your chances of getting into a place and therefore limit your chances of matching. For me, on the flip side, right, is that you probably don't want to work at a place that's going to be caustic to your identity, right? So specifically as a queer individual, I have a lot of conversations with other queer individuals who are like, should I mention that I'm queer? For me, I put my thesis in as a talking point in my CV. So a lot of people asked me that question and I was ready to answer it. But some people are like wondering, especially coming from the South, like, I don't know if these programs are going to discriminate against me. And regardless of whether they're open or not, they're going to be programs that discriminate for whatever reasons and for superficial reasons, right? But then you have to think, right, weigh both of those options, like, okay, where do I think, how strongly do I think, and how wide of a nest have I cast? And do I think that I can like really go there and see with how they're going to respond so that I can know how to rank them, with this idea in mind that they may discriminate against me and not rank me as highly? Or like on the other hand, it's like, I want to see how they're responding. If they're not responding well, I don't want to go here. Like, so it's kind of a push-pull, and it really depends. Like there's also a person who consistently asked who was formerly in sex work and is now trying to be a physician. And they're like, should I bring this up? I don't know if people look me up already. So like, I don't know if this is something that I should bring up. I'm sorry if this is uncomfortable for y'all to talk about. But like, it's kind of like these things, basically like, what things do you bring up? What things do you not bring up? And it's very hard to say. It just like depends on your vantage point and what your goals are, I'll say.
Thank you. I think, yeah, that truly, I feel like, especially, the feeling where you said, on one hand, I'm trying to match, but on the other hand, do I want to match there? I feel like that's you truly captured the essence of a lot of questions that students ask. And thank you for sharing your insight on that. Dr. Diaz Garcia?
Yeah, so like exactly like that. I totally agree. What's really important, although I also think that it's also important to, first of all, it all depends on how competitive an applicant you are in the first place. So, if you're a really competitive applicant and you like cast a wide net to a whole bunch of places, and you got a whole bunch of interviews, yeah, you have the luxury of being able to at least try to express yourself. And this is for anyone, before you go to an interview, you have to really, or before you even think about going to interviews, really take the time to really think about what aspects of your identity and who you are as a person that are super, super valuable, because those aspects that you care about are going to come out in your work and they're going to come out in your everyday life. So if you are in a hostile environment that you feel that your identity can't be expressed, it's not worth going there in the first place at all. Because you're going to be placed under the pressure of feeling like, oh, I can't be me around everyone else. And then you can't do your work, and then you can't relate to your patients, and you can't focus on really giving them the 100% of your attention that they deserve. Because in the back of your mind, you're wondering, well, does my program think this and this about me? Do other people in my program think this and this about me? But then on the other hand, yes, if like you feel like you're not a very competitive applicant, I was not a very competitive applicant, I think it's important to also realize sometimes you have to bite the bullet. And surprisingly enough, regardless if you feel strongly about, the other side of it is, if you feel very strongly about a certain aspect of your identity, you're going to figure out ways to work within the margins and work within the find that fine small space where you can express yourself, because you kind of have to. So those are my 2 points.
Sorry, just wanted to echo what Dr. Diaz Garcia said. I was also not a competitive applicant. And nowadays, I'm seeing like applicants with like, I don't want to scare you, but like with step scores and like achievements that I'm just like, I don't even want to look at this anymore. But so I definitely applied to places where I was just like, this is a biting the bullet thing. But you also have to realize that these are the formative years of your professional career, and like it's going to inform you. Like, it's going to inform how you practice. Like you can say like, I don't want to do this, but then it's like, what are the alternatives? You never learned the alternatives because you went to this one place. So just to get to where you want to go, right? Just to get to your goal, it's like Dr. Diaz Garcia said, it's sometimes you do have to bite the bullet and then do like a lot of learning after you graduate from residency. But hopefully and ideally, everyone just goes to a place that fits them, and they learn a lot and figure out what works for them, what doesn't work for them.
Thank you so much. And thank you for the candid answer. We appreciate that a lot. So one question from the chat was, how do your professional passions define your professional identity? And I think if it's okay, just to add on the question, Dr. Babajide, do you mind sharing if you're going to fellowship and where you're going to fellowship and for what? I already know the answer. And how do you feel like your passions contributed to you choosing that fellowship?
Yeah, I guess I'll answer the first question. And that's like a class. Professionalism is kind of like something that people in power just create. So there's no like one way, like what is professional in psychiatry is not may not be seen as professional in surgery. What's professional here at NJMS is probably not professional at UC Southwestern, which is where I went to school. So it really just depends on who's in power and what they tell you professionalism is. And then you just abide by those rules. And I feel like it's kind of, it definitely has shaped me because I've become more malleable. I'm able to compromise whatever parts of my identity I need to in order to get my work done. Because I'm just trying to get through right now. I don't know what that's going to look like as an attending, because that's going to be more of a solid and like long-term work environment and not like residency or medical school. But right now I do pick my battles, even though I'm sure a lot of other people are like, really, you pick your battles? But I actually do pick my battles now. And so in order to achieve my goals, but going to the second question, I'm still able to, in other ways, relay what my passions are. My passions are working for marginalized populations. No population in particular, but a population that, so I'm going into transgender psychiatry at Mount Sinai next year for my fellowship. And this was a particular population that I felt that I needed to, in order to care for them, I needed to do a lot more learning and training with. So that's why I decided to go into this field. And it's a pretty difficult subject to talk about because, like I said way back in one of those other questions, psychiatry does pathologize trans people, and so it is something that I kind of have to negotiate. Like, I'm going to be training in something where I'm going to have to also be traumatic towards, in some ways, to my patients. And then how do I mitigate that through the work that I do outside of psychiatry? And what does that look like? So professionalism is basically just decorum.
Thank you, for speaking so openly, and I can definitely understand the comment that you said about, oh, do you really pick your battles? Because just for people that don't know, I attended NJMS and I've worked with Dr. Babajide in the past in psychiatry, and he's truly one of the most open physicians I've worked with, and his patients do love him a lot, and I'm very grateful he was able to log in today and speak with us so freely. Dr. Diaz Garcia, do you have anything to add about either questions asked?
In terms of the first question was about professionalism and building professionalism in your professional identity in residency.
It's how your professional passions, I guess, interplay with your professional identity, whatever either mean to you, or I guess identity and professionalism.
I don't know. Yeah, there's different, like Lukman was saying, or Dr. Babajide was saying, there's what's professional. Yeah, what's professional in every field is different. It really varies. And it really varies by location. You kind of sort of have to feel it out depending on where you are. To a certain degree, you have to have some sense of what you feel is professional for yourself and how you want others to be professional around you, if that makes sense. Start there, and then after that, go towards kind of sort of teasing out how other people react to how you feel what your view of professionalism is. At some point, I feel like, especially like, for example, like the reason why I want to go into consultation, liaison psychiatry is more of the aspects that, you know, being able to advocate for my patients on the floors. A lot of times, everyone's kind of sort of ignoring all the other social, personal aspects of our patients and the communities that they come from, that I feel that it's my job to try to address those things. And sometimes you have to kind of sort of put your professionalism in line to be able to protect them and be able to have their voices heard to their primary teams. And those are things you, when you're considering building your professionalism, I think also consider being able to, so think about when you're willing to put your professionalism in line and risk it. And that's like something important to really know and have.
Well, we're almost at time, but thank you both so much for participating. And unfortunately, I'm very sorry there's a couple questions in the chat that just came up, and I'm very sorry I won't be able to answer them. But again, thank you both so much for participating and for answering to all these questions. We really appreciate, all the time that you carved up on this morning.
I can put my email. I can put my email in the chat, and then if those people want to send the questions to us, feel free.
Oh, thank you so much. Oh, great. Yeah, it's there. So yes, I'm sorry we weren't able to answer all the questions in the chat, but this was amazing. Thank you so much, and I hope you enjoy the rest of your weekend.
Thank you.
Yeah, and feel free to hang back if you want to, or I know you're very, very busy, but
oh, I still have time, so I can stay for a bit.
Oh, okay. So we're gonna be starting actually the next session right about now. So Dr. Nelson, are you still there? Hello, Dr. Nelson. Oh, great. Awesome. So Dr. Nelson, he's the professor and chair of Department of Emergency Medicine and chief of Division of Medical Toxicology at Rutgers, New Jersey Medical School, affiliated with University Hospital. He is a member of the board of directors of the American Board of Emergency Medicine and the Accreditation Council for Continuing Medical Education, as well as the Association of Academic Chairs in Emergency Medicine. He is also the past president of the American College of Medical Toxicology, or ACMT. He is a consultant to the CDC, the FDA, GHS, and he has worked closely with several professional medical organizations such as ACMT, ASM, SAEM, and ACEP. He is also the editor of the textbook Goldfrank's Toxicology Emergencies, and he's also the editorial boards of several journals. He provides direct clinical care to patients in the ED, and he serves as senior consultant to the New Jersey Poison Information and Education System. He completed his residency in emergency medicine at Mount Sinai School of Medicine, and he also completed a fellowship in medical toxicology at the New York University School of Medicine. Thank you so much for joining us, Dr. Nelson.
It's my pleasure. It's great. That was a good session before.
Thank you for also carving out the time this morning to participate, and for also listening to our previous session as well. So as usual, please feel free to drop all of your questions in the chat. If something comes up, you can direct them towards me, and at the end, we can ask those questions. So I'll be starting off with some pre-written questions, if that's okay, and then we can start with the chat. So the first question would be, so what interested you in the topic of toxicology as well as the topic of cannabis during your training?
Well, cannabis wasn't really an issue during my training. I mean, it was, I'm technically a PGY 31. So, I mean, we've been smoking cannabis for a long time, but it's really only become a big kind of, highlight over the past, say, 10 years or so. But, I don't know if everybody knows what toxicology is, or I should say medical toxicology. So obviously toxicology is a study of poisons. And most people, when they hear the word toxicology, think about, if you're watching the George Floyd trial now, for example, they keep talking about toxicologists. And most of the toxicologists they're referring to are people who work in labs. and do analytics, right? They put a sample in a machine and they spits out an answer with a GC, MS, some of these fancy machines. Or they do research looking at the harmful effects of chemicals on mice and rabbits and things like that. I don't do any of that. I'm a medical toxicologist, which is a physician who specializes in the care of people who've been exposed to various, noxious substances, poisons, and a big part of what I do, and a big part of my career segued into addiction medicine. I got board certified in that a few years ago as well. And I spend a lot of time at NJMS and UH working on substance use. But again, toxicology is a subject of the day, is really about harmful effects of things on people. And originally, when I really got into the specialty during and after residency, I was very focused on studying cardiovascular toxins, things that affect the heart. And then over time, I got very much more redirected to the opioid crisis. And I've spent the past 15 years of my career really dealing with the opioid crisis. And you heard I do a lot of outside work, and a lot of the work I do with CDC and FDA was specifically about opioids, particularly the extended release and long-acting opioids like OxyContin, and the harmful effects that they have on people. And like a lot of, like we're going to talk a little bit about with cannabis, there's, with almost every medication or drug, there's always a balance between good and bad effects, right? And what we try to do in healthcare is manage risk while providing benefits. So that risk-benefit relationship is active in every clinical decision that we make. You may not think about it that way, but and some things are so obviously beneficial and some things are so obviously risky, you're not going to do them. So most of the things that kind of make their way into the discussion are things that are sort of straddling the line, that in some people the risk is greater than the benefit, and other people the benefit is greater than the risk. Right. And a great example is chemotherapy, right? Particularly the older chemotherapy, not the new stuff, but chemotherapy is very damaging. I mean, people lose their hair, they have a lot of diarrhea, they have their immune system gets disrupted, and they have all these problems. And you wouldn't give it to somebody because they have, a migraine headache, right? Because the risk is obviously too great. But if somebody's dying of cancer, you'll be willing to take the risk of giving a medication that's that damaging, right? And that's a lot of what we do in medicine, and that's what I do. Now, as you can imagine, given my background in medical toxicology, I tend to be a kind of a dark side person. You can say I'm a pessimist or whatever you want to say, but I tend to look at the equation, risk-benefit equation, from the risk side. And is there a way to mitigate the risk to make this drug beneficial? Most physicians look at drugs from the efficacy side. Right. And that's really important to think about, because most of you won't become toxicologists. Some could probably say none of you will. But you have to remember that when you look at a drug and you say this drug, cures whatever 30% of the time, which is pretty good because most drugs don't work that well, you really can't end there. Right. You have to say, what's the risk? You have to say, what's the cost? Right. And that's something that we really are facing now with healthcare financing. And you're probably young enough in your career, you don't think about this very much, but you realize that somebody has to pay for things in this world. And that's a big problem that we're facing. The chemo drugs that used to cost, $1,000 are now costing $250,000. And they're safer, right? They're not that much better, but they are safer. And you have to say, what's the value, right? So anyway, a lot of this is how I got into what I do. And I've increasingly gotten involved with these sorts of health policy sorts of discussions and decisions. I think it's been really interesting. So medical toxicology is a field you don't have to come to through emergency medicine. I mean, if any of you wind up, there are some psychiatrists, believe it or not, who practice medical toxicology. Yeah. It's a really interesting field because a lot of what I do involves suicide, right? And depression. And there's a big disconnect between medical management of these issues and post-medical management care, just like we've seen in addiction medicine, right? Because addiction medicine is a specialty that's really sort of straddles a line between medicine and psychiatry, right? In addiction psychiatry, there's a lot of therapy and counseling, and but in addiction medicine, it's mostly drug-based treatment. Right. And that's sort of where medical toxicology falls in place with psychiatry. We really take care of the person right now and sort of given the mezzanine, and then often, and many addiction psychiatrists like the ones we have here, you know, Petrus Lavonis and Aaron Zerbo and others, have really transitioned to the medicine side, right? But there's sort of two sides of a coin, and they're very integrally linked, but they are slightly different. So that's a long answer to maybe a simple question. So if anybody has any thoughts about that, I'm happy to answer them. You can put them in the chat and I'll try to monitor it.
Thank you so much for this introduction, and for this very nice crash course for medical toxicology. I do feel like we're not really exposed to that. It's like we know it exists, and there's some very smart professionals that take care of it, and then that's that. But thank you for the introduction. So I guess the first question would be like, what do you believe is the current opinion and consensus of the use of cannabis in medicine, and how is the current culture in medicine framing this overall consensus?
Yeah, that's a great question. So, going back to the original question, so when I was a resident and early on in my career, cannabis just it didn't really rank much in the way of harm. I mean, it's a pretty safe drug. I mean, in the world of substances that people use, cannabis is pretty benign, right? I mean, if you look at, you could imagine going back to the inception of humanity, and somewhere we had to choose what drug would become the primary substance of use among humans, and you were given the choice of cannabis or alcohol, right? Cannabis would be a much better choice, honestly. Alcohol is devastatingly bad in so many ways. Probably the biggest reason alcohol is bad is because it really impairs your decision making, right? And you hate to say the kind of the stupid human tricks that people do when they're drunk. Cannabis pales in comparison, right? Even if you look at driving while intoxicated with alcohol compared to driving while you're impaired with cannabis, totally different. Right. Somebody that's driving high doesn't drive at 90 miles an hour and weave in and out of traffic. In fact, their following distances are greater. They drive slower, if anything. Right. So it's a very different dynamic. You think about bad decisions about trauma and, sexual assaults and just bad decision making in general. It's all alcohol related. Right. So, and the harmful effects of alcohol on the heart and on the brain and on our metabolism and our liver, just devastating. And cannabis is not risk-free, but clearly it's better than alcohol. So when you look at it from a lightly used substance, it's better than alcohol. But there's where the question is better than alcohol mean it's good? Right. And that's the question. So, and I'm not saying that everybody should live a life eating, just nuts and berries and never taking any risks in their life. But you have to sort of say, where's the balance between risk and benefit in this? And most people have kind of felt that it's an okay risk to be taking, right? And I'm really talking about recreational cannabis use. But all of you went to college, and all of you know that there's always some people in your dorm or your life who just have impaired decision-making and demotivation and all kinds of problems related to their substance use. And often that's related to cannabis. So it does have those effects. It's not a risk-free drug. And then we get into the real question about medical marijuana, right? And we are not as a medical system going to solve the problem with people using cannabis in a recreational fashion. Right? We can't stop people using cocaine or heroin or whatever drug they choose to use. We're just not going to be able to fix it. We can try to help them. We can try to counsel them. We can try to risk mitigate. We can do all those things, but we're not going to prevent it from happening. The DEA is not going to prevent the drug from coming into the country. We're not going to convince people. Your parents aren't going to do it. Friends aren't going to do it. People are going to use substances. The real question, and I think maybe the best topic for today, is where does it fall into the world of medical use? Right, and whether we should be recommending it to our patients, and it's that same dichotomy that we have to address. What's the risk and what's the benefit, right? And that's what we have to come up with. And there really are not any good answers at this point. So as I preface this by saying I'm a toxicologist, a medical toxicologist, so I'm a dark side person. So I can tell you right now that I am not a supporter of medical marijuana, medical cannabis. I can tell you that most of the psych faculty here are not really falling in line with medical cannabis. But I can also tell you that almost all of the non-addiction medicine faculty think it's the greatest thing since sliced bread, right? I think it's going to solve all the ills of the world. And it drives me crazy, right? You know, as you know, having done a lot of work with FDA and other groups, we always meet and discuss the efficacy data and compare it to the risk data, right? And there's no right number to how much better something has to be compared to its risk before it's okay to do, to use, to recommend. But remember, FDA is not involved at all with the whole medical cannabis issue, right? And the data to support it is weak. You know, there's this old expression that says, "In God we trust, but everyone else must bring data." You know that expression, and you need data in order to make decisions, right? And you know, there's a lot of reasons people, you know, say they don't have data. A lot of excuses for not having data. But that even if all those excuses are correct, it doesn't mean we should embrace something that doesn't have any data. Right. If that makes sense. And I'm happy to entertain questions. And in fairness, you're all allowed to disagree with me if you think that if you fall on the side of medical cannabis, it's good. You know, it's big money. Right. There's a lot to be made. There's a lot of libertarian issues mixed in there. And so, you know, I'm not a prude, and I'm not you know, I have my own libertarian beliefs like everybody does. And, you know, there's big government and there's little government and all those things. But you really have to ask the medical question whether or not there's data to support its safety and its safety over, it's a safety over efficacy. Sorry, it's efficacy over safety. In my mind, those data don't currently exist. And we could talk about specifics if you'd like.
So I guess that's you know, talking about data is a great transition to the next question, which is, what do you believe in our current research topic priorities when discussing cannabis use in medicine, and what sort of data are we lacking in the literature? Because as you mentioned, that we don't have a lot of solidified data since this is a relatively new topic to medicine. And if let's say you had your own institute of research and you could pick which data we would be able to study better, what do you feel like should be those priorities?
Well, you know, here's one of the problems with medical marijuana. There's almost no drug that we use that is better in its original botanical form than in the extracted pharmaceutical form. Right, so you think of opium. We don't use opium. We use morphine. Right, you think of purple foxglove. Well, we don't use digitalis purpura. We use digoxin. Right, I mean, there's no drug. We don't give people colchicum autumnale. We give them colchicine. Right, we don't give people the drug. So there's no reason to believe that there aren't components extracted out of a cannabis plant like THC or CBD that might have some specific benefits. But it's hard for me to believe that this is the one plant in the world in the existence of humankind that is better in the botanical form than it is in the extracted pharmaceutical form, right? So I'll start with that by saying that and remember, there are several preparations of THC, tetrahydrocannabinol, right, which are pharmaceutically approved. One is for appetite stimulation in people with end-stage disease or HIV. One is for chemotherapy-associated nausea and vomiting. Neither of them work very well, but they're there. And, you know, if it doesn't work in the extracted pharmaceutical form, there's not a really good reason to believe it would work in the botanical form, right? And then recently, there's a CBD prep that got approved for a very unique set of infantile seizures called Dravet syndrome or Lennox-Gastaut, which people have sort of jumped on the bandwagon saying, well, you see, if it treats these generalized pediatric seizure disorders, it must be good for all seizures. And there's no data, again, to support that use, right? And that's the extracted CBD form. But when you see a medication that treats everything, which is what they're basically claiming cannabis does, then it probably treats none of them, but it treats an epiphenomenon. Right, that link to all of them. You know, you see a lot of diseases now that have in common things like tiredness and lack of motivation and, you know, very protein vague symptoms like nausea and weakness. When you start to see that, the findings line up very nicely with what psychiatrists would call depression, right? So if I give anybody with one of these syndromes an antidepressant, they get better, right? Not because the antidepressant treats their underlying medical problem, but because so many of these problems are linked to mental health issues, right? And you could pick a lot of the syndromes that we think about that are associated with chronic pain and other things. So in a way, by giving them cannabis, we are treating them because we're making them feel better, but we're not really treating we're not really treating the problem. We're making them feel good. We're giving them a euphoriant. We can give them alcohol, but nobody would say use alcohol to treat, I don't know, anxiety, right? Or, some inflammatory problem, or Alzheimer's disease, or, whatever, Crohn's, all the things that we're saying cannabis is used to treat, right? But it definitely makes people feel better, right? And remember how important even the placebo effect is in healthcare, right? 95% of people get better on their own without doing anything, right? And the placebo effect definitely makes people feel better. I think most of you are probably going to become psychiatrists. And I think as a psychiatrist, you must understand the placebo effect, right? And how unbelievably powerful it is, right? And you also must understand the nocebo effect as well, which is the opposite of placebo effect. Everybody knows placebo effect. Here's a red pill, it's going to make you feel good, and you feel good. And here's 2 red pills, it's going to make you feel better than 1 red pill, and a blue pill might make you even feel better, right? But the nocebo effect is, here's a red pill, it's going to make you feel lousy, right? And here's 2 red pills, are going to make you feel even more lousy, right? Very powerful. We see the nocebo effect these days in police officers who get exposed to fentanyl, right? And they all suddenly get symptomatic, when in fact, there's no medical pharmacologic reason to believe it. I think they just have a lot of unloaded anxiety and other things associated with it. But it's the same thing with cannabis. And all of the, if you wanted to put together a research priority, I think we have to do real studies that look at real issues, right? And we have to do them the right way, right? So most of the science that's out there, so you remember one thing about data, and I'm happy, I know I'm talking a lot, but I'd rather see some questions come up in the chat. But one thing to remember about data, Mark Twain said there were 3 kinds of lies, right? You know what the 3 kinds of lies are? There are lies, there are damn lies, and there are statistics, right? And it's a famous quote, you should know, it's a good quote. There are 3 kinds of lies: lies, damn lies, and statistics. And what that means is that you could make the data show anything you want. And so if you're a dispensary, or if you're predisposed to believing in medical cannabis, and you want to put together a study to show that medical cannabis works, you can do it. And if you want to make a study that shows it doesn't work, you can do that too, right? People say if you torture the data long enough, it'll confess to anything, right? So basically, you just get it, you just tweak it, you twist it, you post hoc analyze it, you do anything you want, you can make that. So when you look at a lot of these studies that purport to show a benefit to medical cannabis, look at the source, look at who's doing the science, try to understand what their perspective is. And I know I'm coming across fairly cynical, but I hate to say it, you have to be, right? Because more now than ever, the hand of pharma and the hand of other groups that are predisposed to one perspective or another are strongly mixed into the data that we produce. And even the journals are complicit to some extent with some of this, with open access and other things, open access journals. So you have to be really careful. So I think if we're going to make any progress on this, we need well done, double-blind, placebo-controlled. And placebo is tough with cannabis, right? Because it is psychoactive, so you sort of know you're getting it, right? So we might have to use active comparators to do it, right? Which makes it even trickier, right? So you can't just give somebody a sugar pill, you have to give them something else that makes you feel good, right? And again, it's hard to do that. And you need them done in a credible way by a credible researcher with adequate oversight, right? Not funded by a maker of one of these, consumables or smokables, but You need it done really well. And I think there's undoubtedly going to be a benefit, right? Because as I said, alcohol would make you feel better. Cocaine would make you feel better. This is going to make you feel better. So we need a risk side of the equation also, right? It can't just be an efficacy study. There's got to be a risk component. And then we have to do some science and figure out which one is safe and which one is effective. So that would be my general answer. To my knowledge, there's not credible data that it works for anything, even for the things that the FDA has approved it for. Remember, the FDA approved it for HIV-related weight loss back, in the 90s, when this was a major concern and there was a lot of optics looking at the use of this medication, right? And most people don't use it for that anymore because it doesn't seem to work.
Thank you for answering that question. So we actually had a couple questions in the chat that come up. And if that's okay, so they were sent directly to me, but I can paste it in the chat. And it says, so would you be able to talk about how to counsel a patient who presents with a medical marijuana card and counseling them specifically on the safety concerns? And that was the first question. I guess I can ask the next question after this.
So there are two safety concerns that come along with pretty much with every drug, right? There's acute concerns and there's long-term concerns, right? The acute concern for cannabis, really, assuming you're not overdosing on it and you're taking an appropriate dose, have to do with impairment, right? As I mentioned earlier, that the decision-making, the judgment, the executive function impairment from cannabis is less than alcohol, which is true, but it's not zero, right? So it's still not safe to drive a car or invest your money or, go to risky places, those sorts of things while you're using medical cannabis, right? I mean, CBD has no psychoactive effect. So with CBD, and I'll say this kind of tongue in cheek, you're basically just throwing your money out. And I guess I can't stop people from throwing their money out, right? Another great quote about a fool and his money, right? But if it makes you feel better because of the placebo effect, that's okay. But the science doesn't support that it has any value, except maybe in Lennox-Gastaut and Dravet syndrome, which none of you, I can assure you, have. For the THC or the botanical part, which is all pretty much psychoactive, bad decision making is a big problem. It's hard enough to make decisions when you're kind of not impaired, right? So the long-term consequences we don't really know enough about. Now, in New Jersey, all medical marijuana is smokable marijuana. It's botanical. In some states like New York, none of it's botanical. You can't give out botanical marijuana. You have to give out derivatized marijuana. So, it's a hodgepodge of rules across the different states about how cannabis is used in these programs. But the long-term consequences are real. I mean, we know that there are psychiatric implications of long-term cannabis use, both psychotic related, if you're predisposed, and there's probably a large genetic and predisposition component to psychosis related to cannabis. And there's also a big chicken and egg question that comes up, right? Do people with mental illness use cannabis to control their mental health? Or do people use cannabis and develop mental health issues? And that's a debate, and it's probably the answer is going to be both, right? But there are these less, not psychotic features or diseases, but amotivational syndromes, and again, the things and addiction. Addiction is a big issue, right? And whether cannabis is a gateway drug or not almost doesn't matter, right? Because we know that people make bad decisions when they're using cannabis. Right. So I would agree with those that say most people use cannabis don't go on to shoot heroin. Right. And so that's not a gateway drug. But I would also say that some do, so while it's not a gateway, it's not like, if you go back to the 1940s, there's a great movie called Reefer Madness. If you've ever seen it, it's probably online. It's almost like tongue in cheek at this point, how ridiculous it is. But it made it seem like if you smoke a joint, you're going to wind up, crazed for the rest of your life. But that it's not that global, but there are some people that happens to. You can say the same thing about opioids, right? Most people take opioids, don't have any problem, but look at where we've gotten with opioids in this country. You know, they now say we had 90,000 deaths last year from opioids. That's the preliminary numbers that we have for the past year. Most years before that, it was ranking in the 50 to 60,000 range. But, you know, because of COVID, it looks like those numbers went up. But right, most people that get opioids don't die of an opioid overdose, but some do. And, you know, and cannabis is not an opioid. And I'm not trying to frame it that way. It's much safer, much less of a problem, but it's not risk-free. That's all.
Thank you for the answer. There's also another question that came up in the chat. I'm going to paste it. It was also sent directly to me. And it says, question for Dr. Nelson about recreational use. Since we already know our patients will be using cannabis recreationally, how would you advise us to counsel them to use it safely?
Yeah, this is all harm reduction. And you know what? I'm actually more in favor of recreational or what we call adult use cannabis than I am for medical cannabis, right? Because I do sort of believe that people should be allowed to make their own choices. That doesn't mean we should just let it out there willy-nilly. And I don't support that same position for cocaine and opioids and things like that. I personally don't think people should use cannabis, but I do think people have the right to use it. So for recreational cannabis, I don't think we're going to, you know, again, the horse is out of the barn for the most part. So we're not going to be able to close the door and get the horse back in. So we know people are going to be using it. The two issues that we feel that I see with recreational cannabis nowadays, and of course, you know, the social justice benefits being incredibly important when it comes to one of the reasons to sort of legalize it, although that could have been handled through decriminalization and not necessarily legalization. But I think the two big issues are use safely, right? Harm reduction. Right. And harm reduction, I say the same thing. We know people use opioids, right? But you should use opioids safely. You should, you know, use clean needles if you're gonna shoot. You should do it in the presence of others. So if you overdose, there's gonna be somebody to resuscitate you. You should have naloxone available. You know, all of those things that go along with harm reduction. And the harm reduction for cannabis isn't necessarily to that same degree, but it's don't drive a car, don't, you know, make, you know, big decisions while you're intoxicated and things like that. But the other issue with cannabis is that, so when I was in college, you know, pot had 3% THC in it, right? You literally have to smoke 3 joints before you take on enough THC to have any, you know, concerning acute medical effects. And there are concerning acute medical effects. A lot of people get bradycardic. There's a bit of pulmonary toxicity that goes along with it. Syncope and, you know, and dizziness and a lot of neurologic effects from having too much. But with today's cannabis, you know, it's not uncommon to find 15 or even 20% cannabis in botanical weed form. And then you can get up with, you know, wax and other forms of cannabis. You can get up to 90% cannabis. I'm sorry, 90% THC. You're talking about one hit bringing you to the point at which it would have taken us an entire joint to get to, right? And people overdose very readily, right? We've seen little kids get into gummies and other things. You know, we had a kid. It's amazing. I mean, some of the stuff you buy now that's the edible form look exactly like the real product. So we had a kid who got a bag of Skittles from somebody and started eating the bag, and it turned out they were medicated Skittles. Right. And the kid took on 400 milligrams. This was a little like a 4-year-old, right? Or a 6-year-old, something like that, took on 400 milligrams of THC, right? From that bag. Now, it turns out that an adult dose of THC is about 10 milligrams, maybe 20 or 30 if you're kind of used to using, but nobody's taking bigger doses than that. So to eat 400 milligrams, the kid was intubated and in the hospital, in the ICU. Right. So it's not risk-free. So the dose issue is a big deal right now. And the truth in labeling is complicated because not every state has good regulations about recreational cannabis and how the labeling has to be done. Right. A single serving is 10 milligrams. So you might be good at this and take 2 or 3 servings, but you should know what you're getting. There's a great piece in the New York Times from, I don't know, about 8 years ago by Maureen Dowd, who's a columnist. She was visiting Denver And she said, well, when in Rome, right, and Denver had just had their recreational marijuana dispensaries open. So she went in and bought a cookie, right? And she took a piece of the cookie and didn't feel anything. So after a few minutes, took another piece of the cookie and didn't feel anything. Then she took another piece. And by the time the hour passed, she'd eaten the whole cookie, and then it kicked in, right? And the cookie was 17 servings. It was 170 milligrams of cannabis, right? So the cookie wasn't labeled that it was 17 servings. Who the heck is 1/17 of a cookie? So obviously there were some problems with the way things were labeled, and she describes her entire experience in very detailed and well written as a columnist would, prose in the New York Times article. So if you look it up more in depth, it's short. It's a really interesting piece to read about how people get in trouble. So that's what you really have to counsel people about, is the short-term problem with getting too high, right? Both about decision-making and the physiological effects, and the long-term complications and implications of addiction. Addiction's a big deal, and you can't ignore that.
And thank you for answering that question from the chat. So there's also one more question, which is, so what are some good resources for students to use to stay informed about evidence-based protocol, statistics, news, and research relating to cannabis use, both recreationally and medically?
Yeah, you could read the literature. I would really try to stay with credible sources. When things come out in New England Journal or a JAMA or Annals of Internal Medicine, I'd be very, very careful. Mark Twain had another quote that said, be careful reading the medical literature. You may die of a misprint, right? Because there's so much misinformation in the literature today, and it's exponentially worse than it was when I was in training, because there was no such thing as a predatory journal. There was no such thing as open access where you pay to publish, right? You can get anything published today. You could make up a study that is completely fabricated and comes up with absurd conclusions. And if you're willing to pay $3,000, it'll get published in a journal. So you have to know what journal you're reading, what their criteria are for publishing. You need to know who supports that journal. But if you stick with the big name journals, I don't know the psych journals well, but I'm sure the American Journal of Psychiatry or some equivalent sort of journal, you'll probably be okay, because they have methodological and statistical editors that review the data. They have a pretty credible group of people that are peer reviewers. I would stay far away from anything that's got one of those inherent biases, like paid for publication sort of things. And there are some credible open access journals, and I don't want to be too negative, but you have to know which ones are which, because the vast majority of them are not credible, right? And I get probably, 15 emails a week, maybe 15 emails a day from predatory journals asking me to publish in their journal for a fee. And to lecture at their conferences, the predatory conferences, another issue that we just have to deal with, and deciphering which ones are real and which ones are fake is really hard. Sometimes it's really easy, because when you read the thing, it's not even written in English. It's written by somebody who doesn't have a strong command of the language, and it's not coming from a real journal. But it's hard. It is very hard. Hope that answers the question. There is no way that you have to read the literature, you have to look at the source, you have to know enough about evidence-based medicine to understand whether or not it's credible. You might have trusted colleagues who can help you interpret it if you don't understand the material. Not everybody has to be a researcher to do this, but I don't think you should accept at face value something that's written just because it's out there in the world. And I certainly would be careful about blogs, and those kinds of things where people just spew opinion, and it's not evidence-based, it's often very biased, right? And you just have to be very careful. It's caveat emptor, right? You got to be very careful.
Thank you, for answering all the questions. I think we're basically up to date with the chat in terms of questions. There was a recommendation for a book about statistics that John Amoroso shared, and also Ravent, please let me know if I'm mispronouncing your name, also said that he appreciates you sharing openly about medical marijuana and hearing the counter argument that's usually presented. And also more people are thanking you in the chat. So thank you so much. This was a very requested topic to, learn about, and thank you for carving out this time. And I hope you're enjoying Chicago.
Thanks, everybody. Have a great rest of your conference.
Thank you. And enjoy the rest of your weekend.
Thank you too. Thanks for having me.
Goodbye.
Bye.
Okay, so I know we're a tiny bit ahead of time. So if it's okay, Dr. Mintz, are you okay with me introducing you? And
yes, sorry,
okay,
my mic was off.
Oh, no worries. I mean, maybe we can start a minute and a half early. I know we have a very interesting topic ahead of us. So Dr. Mintz is a staff psychiatrist who joined the Austen Riggs Center in 1996. He is currently the Director of Psychiatric Education and the Associate Director of Training, as well as a team leader at Austen Riggs. He's a principal investigator for the research and initiatives in psychodynamic psychopharmacology. He's also known to be a speaker about evidence-based medicine relating to psychodynamic psychotherapy. And he's graduated from the University of Miami School of Medicine, where he was inducted into the National Medical Honor Society. He completed his residency through the Cambridge Hospital Austen Riggs Center Combined Residency Program at the Psychotherapy Fellowship at Austen Riggs Center. And at the APA, he is elected leader of the Psychotherapy Caucus. He also has a psychoanalytic, he is a psychoanalytic fellow, and he's elected leader for psychoanalysis and dynamics. He's a fellow at the American Academy of Psychoanalysis and Dynamic Psychiatry, also known as AAPGP, where he's also elected as a trustee of the Academy. So I don't know if you could tell from me stumbling all of my words relating to psychoanalysis and psychodynamic psychotherapy, us medical students are not introduced a lot to this topic. And by that, I mean not at all. So I was hoping maybe you could give us an introduction to psychodynamic psychotherapy. What does it mean and how is it practiced nowadays?
Sure. So, and actually, I can do this two ways. I have a talk planned, but I think it might be better if we just had a conversation. And so I'm curious about whether the membership here is up for passive learning with your screens off and mics off, or whether you're up for just bringing your questions and talking about what you think of psychodynamic psychotherapy, what kinds of questions you have. I think the latter is probably usually a little more interesting, but you'll get more data the other way. But at this stage in your training, it strikes me that you maybe don't need all the data, that you just need to start to get in your head, what is psychodynamic psychotherapy and why should you be interested in it?
So I was hoping that I think it would, I personally, I mean, please feel free to, contribute in the chat, but I think it would be better to have a Q&A personally. But would it be possible for also, if you have the data, to share it in the chat, that way if we wanted to read about it later, would that be a possibility?
And I can throw up slides here and there if something comes up. So let's do that. So did you have a starting question?
Yes. So again, would you mind defining what psychodynamic psychotherapy means and how is it practiced nowadays for those of us who have like a small idea of what it is?
Okay, so let me just start before psychodynamic psychotherapy, just to start with psychodynamic. So if you think about the word means, it is basically from the Greek, it means mind in motion. And psychodynamic implies, as according to the Merriam-Webster dictionary, the interrelation of conscious and unconscious processes and emotions that determine personality and motivation. So it's a model of the mind that considers there to be an unconscious, that there's a motivation in us to keep certain things unconscious. Things are pushed down out of awareness to come up somewhere else. This part of us and that part of us don't agree. So It's a view of humans as being essentially in conflict. And from my perspective, psychodynamic is then both a way of understanding humans in a much broader sense than just psychotherapy. So I for example, find that I do psychodynamic psychotherapy, but I find that the ways that I apply psychodynamic thinking to psychopharmacology is often just as important and powerful as when I'm doing it as a psychotherapist. So psychodynamic is both that, and then it is a specific technical approach to psychotherapy of people with various disorders. And I could, if you want, I actually can throw up a slide here. Let me see if I can get to this. Share screen. That does, where's that? Okay, here we go. Are you seeing my screen now? Yeah, so Babajide and Hilsenroth did an empirical study of this. So they took a look at people doing CBT and people doing prototypic psychodynamic treatments. And they found in their empirical study that there were 7 distinguishing features, things that happened in psychodynamic treatment that didn't tend to happen as much in CBT. And then there were 6 things in CBT that didn't happen as much in psychodynamic treatment. But so psychodynamic treatment is a kind of therapy that, as they found, involves a focus on affect and the expression of emotion. So you're encouraging patients to talk about what's on their mind, but very often as a psychodynamic psychotherapist, you're paying attention to where the emotion shows up. And even more specifically, you might, as they say, the exploration of attempts to avoid distressing thoughts and feelings. So as a psychodynamic psychotherapist, you're watching like a feeling show up, and then the patient, starts talking about something else real quick. So you are attempting to notice the places where there's some kind of avoidance, because often I think from a psychodynamic perspective, that's where the money is, right? The things that people are really struggling with. You're looking often when you're doing psychodynamic work at identifying recurring themes and patterns. So this kind of relationship blows up. You always, you get into a relationship, as soon as you start to feel dependent or the other person starts to feel dependent, you find a way to blow it up. So it happens over and over and over again. And interestingly, when you get that kind of thing, when you get a story like that about somebody who does that in their lives, as a psychiatrist, I will find very often they will do the same thing with their medications, right? These are the kinds of patients who, if the medication works, they'll say, oh, it worked. I need to get off of it now, I'm fine. And then of course they're depressed again, 3 months later. But the fear of dependency came up and made them blow that medication relationship up because they just couldn't bear the feelings of dependency. There's very often in psychodynamic work a discussion of past experience. So you're kind of a developmental context. How did you come to believe the world worked this way? What were the early experiences? What was the early family environment like, where you learned maybe that you really can't trust people too much, or that if you share your feelings, everybody's going to freak out, or your value of a human is based on what you do and not who you are, or all sorts of like fundamental family values that then absolutely shape who we are as adults, and very often in such a way that it becomes a burden or it's something that gets in our way. So if you learn, you really can't trust people, then you're an adult and you can't trust people and your relationships don't work. Or, if you learn that your value is, that you're more of a human doing than a human being, you work really hard, you do great in your profession and you burn yourself out and then you end up depressed. So from a psychodynamic perspective, we would be paying attention to the very early lessons that somebody just soaked in their family environments to help them sort out. Basically the point is not to get stuck in that, but to help the person recognize that the present is not the past and to kind of free themselves of that. In psychodynamic treatments, there's often a focus on interpersonal relationships. So you're paying attention not just to symptoms, and usually not just the symptoms, but I think from a psychodynamic perspective, we're fundamentally social creatures. And so, if your interpersonal world is messed up, chances are you're not going to be particularly happy, you're not going to be particularly functional. So part of that is also a focus on the quality of relationships, including especially the therapy relationship. So in psychodynamic psychotherapy, if you've probably studying for your boards, you've heard about transference. So the basic idea being that these recurring patterns that we've talked about are almost always recreated in the doctor-patient relationship in some way. And it is often much more powerful to really get a handle on that in the here and now. Like we can talk about over there and that relationship and what you're doing, but the patient can always say, well, you don't understand who that person is. But when it's here in the room, there is a different kind of experience where the patient says, you can't stand me. And I'm sitting here thinking, oh, is that really true? What tells you that? And we have a chance to look at it together right in the room. And from my perspective, there's a way that, if we're talking about that relationship over there, you're engaging the frontal lobes. But if we're talking about this relationship and the patient's having a feeling and we're looking at it together, you are engaging the limbic system and the frontal lobes at the same time. And there's a particular power to that that really can often, because a patient then has an experience of they think they're hated, but I'm not behaving particularly hatefully. And now they've got a conflict and they got to figure out what to do with it. And oftentimes we think of change happening around the experience of that conflict. And lastly, I think in psychodynamics, there's a lot of attention as well paid to fantasy life and free association. So we usually, when somebody starts therapy with me, I will say, there's only really one thing I ask of you, which is to say whatever is on your mind as much as possible without censoring, recognizing that that's impossible, but your effort should be to try. And when you can't, I'd be interested in you also letting me know that something is getting in the way if you're being able to say what's on your mind. And the idea of that is, patients will be over here and over here. And, sometimes that will show you the defensive moves. Oh, every time we start talking about your sister, suddenly we're talking about something else 2 seconds later. Or it will show us in a way that, you talk about this and then you talk about this. And then the next time you talk about this, you also talk about this. So then that starts to say, oh, these things are close together, kind of in the semantic network of your mind. And then that starts to point to the ways that you put the world together. So the idea that we would just, explore your fantasy life, explore your dreams, that all starts to give us information about what's less conscious in the mind. So that's, in essence, I guess that is the nuts and bolts. Now, I guess I will say one other thing. Let me see. Yeah, so I will say also that in terms of the model, now this is Freud, so this has grown some, but as I said, a piece of it is that there is. Oh, you're not seeing this anymore. I just cut you off. Hold on a second. Let me get out of this. Sorry, I unshared. Let me share again. Okay. So just a few other things about this. That it's a model of the mind that Freud discovered the unconscious. Where there's an unconscious, there are defense mechanisms that we're looking at, and you've studied all those because they're on STEP. The defense mechanisms are there to keep things out of awareness that we don't want to know about ourselves. And once you get into therapy, you expect, on some level, patients will fight you because they still don't want to know about, they want to feel better, but they also don't want to know about parts of themselves. So, this is where resistance will come up, where patients will maybe not show or change the subject or fall silent or, act out instead of speaking and those kinds of things. Psychoanalysis or psychodynamics as a model, as I said before, really looks at transference, it pays attention to the doctor-patient relationship. And And one of the key techniques is the use of interpretation, which is we get a feeling based on what the patients say, what they do, what they bring up in us about what's going on unconsciously, and periodically you will judiciously show the patient something about how their mind is working, so that they, with the idea that when you make the unconscious conscious, it stops being in control of you and you start being in control of it. So, okay.
This is truly a fascinating introduction to the topic. Thank you so much. And it was extremely informative. There's a lot of things, like you mentioned, we're on step, but a lot of things we weren't really introduced to in our training so far. So we do have a question from the chat from Maya Zlitny. I'm sorry if I'm mispronouncing your name. So the question goes, in my limited clinical experience in psychiatry, I noticed that there is not enough emphasis in the importance of psychodynamic psychotherapy. Would you agree? And if so, how can we as future psychiatrists change the trend?
Okay, well, I think the trend is changing, but slowly. And I will say, I think the history of this is, if you're interested, is quite interesting, and is one of the ways that psychoanalysis and psychodynamic psychiatry spent a lot of time shooting itself in the foot. Because there were a number of, I think, missteps in the history of psychodynamic treatment that put us in a bad place, maybe starting in the 1929, 1930, when the Harvard psychologist Saul Rosenzweig wrote to Sigmund Freud and said, we're doing research and we are finding empirical evidence to support your model of the mind and your treatment hypotheses. And Freud writes back, basically, that's great, but we already know it works from clinical experience, so we don't really need a lot of research. So right away, so psychoanalysis spent 80 years basically saying, we don't need research, we know this works, which of course was a terrible misstep. And then the other thing I think that happened, two other things I guess that happened. Another one was psychoanalysis, obviously held sway for much of the 20th century as a predominant treatment model. And as biomedical psychiatry was coming in, they tended to view biomedical psychiatry with a kind of contempt. Like, that's just a Band-Aid, that doesn't really, that just covers over the symptoms. It doesn't get at the heart of the problem, which in some ways is probably true, but there was a kind of a dismissiveness about it that set up an antagonism between biomedical psychiatry and psychoanalysis. And then a similar thing happened when Aaron Beck, who incidentally left Riggs, where I work, and started CBT. Psychoanalysis was not receptive to his interest in shifting from the unconscious to the conscious. And so that tended to be viewed with a degree of dismissiveness as well. So when those things started developing an evidence base, I think they treated psychodynamic psychiatry or psychoanalysis with the same contempt that they received. So there was a lot of hostility, I think, towards psychodynamics. And it is really only in the last 25 years that psychoanalysis and psychodynamic psychiatry started saying, yeah, wow, we got to get on the ball and start doing our research. And there's a bunch of research that we can talk about. But at this point, well, I'm curious actually, for those of you that are on camera, how many of you have heard along the way, and if anybody else wants to turn your cameras on so we can have more of an interaction, that would be great. But how many of you have heard along the way that psychoanalysis or psychodynamic treatment is not evidence-based? Yeah. So that's one of the reasons you're not getting it in school, is that that kind of prejudice, and it is, and I think it is prejudice. It's not just that people aren't caught up with the evidence base, because there's been some interesting studies that have looked at what happens around psychodynamic treatment as it enters the evidence base, and there's lots of ways that Abbas, and I can pull up that slide, but there was an interesting paper about 4 or 5 years ago where they really looked at the systematic kinds of kind of unconscious bias directed at psychoanalysis. So it's like things like, you're comparing CBT and psychodynamic treatment, but your psychodynamic treatment is they took some first-year graduate students, taught them psychodynamic treatment for 6 weeks, and then they delivered psychodynamic treatment as if that would be a viable comparator to expert CBT people. And there's a lot of things like this that have happened that, and then they say, oh, look, CBT works better than psychodynamics. And that becomes part of the evidence base. But when you really look at the guts of it, there's lots of ways that the evidence base has been tilted against psychodynamics. And that is starting to change. There's now, there's a guy, Peter Lilliengren, who's keeping you can find it online, a running total of randomized controlled trials of psychodynamic treatment. And it's 280 now, or something like that, is some big number. So there's a really strong evidence base that very big studies really do suggest that it is at least equivalent to, you know what, I can throw up, I'll throw up the slides in a bit, and then I'll point out some of the studies. And the article by Abbas, Abbass, who dealt with the issue of bias against psychodynamic treatment. In terms of what you can do, I mean, I think it's just paying attention to the actual evidence base is one thing. You know, those of you that are, I guess, as medical students, you learn about it. That's a great topic to present when you're asked to present on something. You know, the evidence base for psychodynamic treatment, to help educate the people, you know, the generations, the people older than you, that the evidence base really has shifted since they were, you know, training 20 years ago. I'm trying to think what else you can do to help shift that. I think that's the most effective weapon is you know, really paying attention to the evidence base.
Thank you for that introduction. I mean, thank you for answering that question. And yes, that's absolutely very helpful. So I received a question in directly, and it asked, do psychotherapists usually practice CBT and psychodynamic psychotherapy independently? Is there a way to marry both of them in practice?
Well, this is very interesting. I think most people develop expertise in one or the other, but Ablon and Jones did an interesting study where they asked CBT experts to develop a CBT prototype of what does a pure CBT treatment look like, and they asked psychodynamic people, develop for us a psychodynamic prototype of what a psychodynamic session would look like and what would be happening, what are the techniques. And then what they did was they took seasoned clinicians. So these are seasoned clinicians, people who've been doing this for a lot of time. And one of the really interesting things that they found was that about half the time, raters who were looking at those sessions couldn't tell whether the clinician was a psychodynamic clinician or cognitive behavioral clinician. So I think seasoned clinicians are very often drawing from both. Very often they may be challenging cognitive, you know, conscious cognitive ideas. They may be suggesting, you know, you maybe ought to, you know, work on this one thing and do this one thing, kind of like homework, like you'll get in CBT. And then they will also be not just, you know, working consciously and not just giving homework and doing things that are more kind of behavioral. But if they're a CBT person, they'll be paying a lot of attention to repeating patterns and what's happening in the relationship, and they will be doing all of that. Ablon and Jones also found in that study that though people were doing a combination, like there's a lot of seasoned people were doing some combination, it was adherence to the psychodynamic prototype that most predicted a positive outcome. So even CBT people who were bringing in psychodynamic stuff were the ones who tended to get the best results with their CBT.
That's truly fascinating. Before we move on to the next topic, would you mind just showing us the slides with the studies? I believe there was a question in the chat about the name of the studies. It seems like we just want to read more about this, again, due to the very limited exposure in medical school.
Okay, so here, let me pull this up. So this is the ABAS, which is maybe is the one, and there's we will the actual, and I'll get to the Avalon and Jones too. But,
are you sure? Oh, thank you. Awesome. Thank you.
There we go. So the ABAS study, that what they looked at was there was distorted depictions of psychodynamic theory based on caricatured versions. And actually just last week, just as an example of this, I was speaking to somebody and they said, well, you'd never want to give psychodynamic treatment to somebody with a substance abuse problem, because that's all about unleashing the id, and you don't want to unleash the id in somebody who's abuses substances. And while there's that reflects a corner of 1920s psychoanalysis. It wouldn't be even all of psychoanalysis, but there was a corner of psychoanalysis in 1920s. It was very focused on just that kind of like, if people unleash their id, then they'll be less neurotic. But it would be kind of like me saying, I don't believe in interventional radiology because, in 1950, they used to irradiate kids for acne and caused a lot of cancer. It's like looking at something in the past and using that to discredit the whole model 100 years later, right? So there's those kinds of things that happen all over the place. Studies get excluded for weird reasons. Psychodynamic researchers are often, a lot of the bodies that like provide grants and these kinds of things, they have just include no psychodynamic people at all. It's all CBT and behavioral and medical. As I said, use of restricted versions where you have like, first year graduate students who've done psychodynamics for 6 weeks, and then study selection. So that's the ABAS. And if I have to zoom way ahead for the, yep, and so here's the ABAS and Jones, 1998.
Thank you very much. And there's a couple of questions. Well, I think it's 3 now in the chat, and those are about, I guess, just different topics. So Vaishali Namdev asks, should there be an active effort made to avoid transfers and counter transfers in the process of psychoanalysis, especially when it comes to discussing developmental trauma? And adding to the last question, is there a way to tailor the awareness of cognitive distortions from CBT to challenge the perception? Thank you for that question, Vaishali.
Okay, well, I mean, I will say, first of all, I don't think you should, I mean, you could try to avoid it, but the thing is you can't avoid it, right? I mean, I think that at least from a psychodynamic perspective, patients have a model in mind of what people are like and of what the risks of engaging with people are. And that is going to show up. And that is likely what is interfering with their lives, is just the anxieties, especially somebody who's been traumatized. You don't want to traumatize somebody more, but you do want to draw attention to the ways that you are, treated as a potential rapist or those kinds of things, the ways that anxiety shows up in the relationship. So the patient, again, can begin to differentiate past and present. And similarly in the countertransference, patients who, I mean, I have a particular thought about this. You may have learned, you may have heard people talking about, compartmentalizing and putting those feelings over to the side. I think that's a mistake personally, because I think we need all of ourselves. And I think that that's just that's kind of like dissociation, right, that our patients are doing. It's more about, how do I say this? Okay, so a good example would be projective identification. Does anybody want to give me who's taken step already, a definition of projective identification?
From my understanding, which it was a long time ago that I learned definition, it's when a patient projects something, but it's when it gets under your skin that it becomes projective identification. So like, let's say I'm someone who's insecure about a mole on my face, but like patient says, I think it's very interesting how you're able, you're so brave, and you're, walking around with this mole on your face, and it's just projection, I guess, if the patient also has a mole, or they're just saying that. But if it does get to me, then when it becomes projective identification, that's from my understanding. So correct me if I'm wrong.
Yeah, no, that's a great example. So the patient would take their own insecurities. It's not about their mole, it's about their insecurities. And so they notice something in you to bring that out in you. The example I like to give is, like, I'm not an angry person, and you're my therapist, and something has happened where you did something that irritated me, and I'm like, I'm not angry, but the pen is going and going, and eventually you say, would you stop with the pen? And now I'm like, God, I don't know why you're so irritable. It's just a pen. And in that moment, I am no longer irritable, right? Now you're the irritable one. I'm just like, come on, just chill out, please. Don't be so cranky. So a way that people take their unwanted feelings and actually inject them into other people. And I think that our job is not to not get angry. Our job is to notice, oh, I just got angry. What does that mean? Oh my God, the anger I'm feeling right now, this patient probably lives with this feeling all the time. So rather than it being something that is in the way, you don't want to act on it. You use it as basically a path to empathy. Like you feel it, you step back a bit from it and look at it. And I often think, I don't know how many of you have seen the movie The Matrix. Like there's that scene at the end, right, when he's shot, and then he gets, like something happens, and the transformation is starting to happen, and he stands up, and all three agents point at him and shoot, and then you see the code falling, and he just puts up his hand, and the bullet stops like right here, and he just takes the bullet and he kind of looks at it, examines it, and then it lets it fall to the ground. I think when, like at least when you get good at doing psychodynamics, that's what you do with countertransference. Is you feel it, you let yourself feel it, and you examine it for what it helps you understand about the patient. And interestingly, once you do that, it does not feel so terrible anymore, right? Because you know that you're having this feeling on behalf of the treatment, right? On behalf of the patient. Now, I will say it takes some time to get there, so when you're a psychodynamic therapist, there's a certain amount of suffering you do on the way to being able to step back and look at that feeling. But I think it's a developmental process in becoming a psychodynamic psychotherapist.
This is a great transition to our next question in the chat. You were talking about how, once you have the experience and you become a seasoned, I guess, psychodynamic psychotherapist, the question asks, how would you define being an expert in a type of therapy? In addition of years of training and exposure, I am curious how we can measure or evaluate the efficacy of these modalities and our efficiency or expertise.
Oh, it's interesting. I've never quite thought of it that way. But how do you know when you're expert, I guess is basically the question. I wonder if I could shift it a little bit to what are some of the things that you develop in yourself. So I think that there are, certain clinical virtues that, first of all, that you're trying to develop a kind of psychological mindedness, empathy. And again, how do you measure empathy? You kind of know it when you see it a lot of the time. A non-authoritarian approach So one of the interesting things, and one of the things that I think attracted me to this model is really the point is not, I think, at least the way I think of psychodynamic treatment, that I am not the expert. What I am is I am not the patient. I am outside of their experience. So I have a chance to look with them at their experience. But I think to do that, you have to have a kind of a non-authoritarian stance where you don't think you have it all together, or you know, you're not the one who's right. And in fact, I think oftentimes well, there's a book title by a Lacanian psychoanalyst that I like called "Knowing Nothing, Staying Stupid," which I think you know, speaks to the optimal psychodynamic position, which is we are learning together. Like, I see things, I point them out. It's up to you to decide, does that fit or not? I mean, I don't know anything until the patient knows as well that I suggested something and they said, yes, that feels absolutely right. So a kind of a non-authoritarian stance, willingness to be wrong. So those are some virtues. And then in terms of, you know, capacities, you know, I think, you know, there's a capacity, also a capacity to sit with hard feelings together with somebody without changing the, you know, without acting out, changing the subject, you know, saying, oh, well, you know, maybe you need an anxiolytic right now, you know, when actually it's, you know, you, the doctor, who needs the anxiolytic in that moment. And then there's, you know, there's whatever changes for the patient, you know, that tells you a lot. And I will say, and I would like to throw up a slide about this, if I could figure out where that slide is. You know, one of the interesting things about psychodynamics, so if you're paying attention to what changes for your patients, so basically all of the psychotherapies, especially in this current treatment environment or research environment, a lot of the research looks at symptom reduction, right? So how much less depression do you get? How much less anxiety do you get? And I could throw up some slides if you want that look at psychodynamic treatment and compared to CBT. But one of the most interesting things about psychodynamic treatment in this model, when you're looking at the kind of change that your patients experience, that I think would be a kind of starts to tell you, you know, if you're expert, as if you're getting this, is that psychodynamic treatment not only helps with symptoms, but it is often targeted at a much broader scope, part of the patient's life. Like in one of my papers, I suggested that, you know, when we just focus on symptoms, we really stop being mental health professionals and become mental illness professionals. Right? Health just disappears, unless you think of health as just the absence of illness. But I don't think that's what health is. Psychodynamic treatment actually aims very specifically at that. And let me show a slide of, you know, a study that looks at this. So, so in one study, a retrospective study of over 400 former patients of psychoanalysis or long-term psychodynamic psychotherapy, and again, a heterogeneous group of patients, a quarter of which had affective disorders, but it was a range of things. And at following up with them at an average of six and a half years after completion of treatment, they found that 80% of them reported improved well-being and personal development and improved relationship to others, which CBT or pharmacotherapy doesn't necessarily do much for those domains. 70 to 80% reported improved coping with life events, improved self-esteem, improved mood, improved life satisfaction, and improved workability. In that group as well, 67% of people were in stable partnerships prior to treatment, and after treatment, 76% were able to maintain stable partnerships. So there's a lot of, so psychodynamic treatment, you know, you've got there when your patients have better lives. And very often I think, you know, if I'm in treatment and I have a choice between less anxiety or just a better life and better relationships, I would rather have some anxiety and, you know, be fulfilled in a bunch of other ways than to have my anxiety treated and have all my other life problems, you know, still in my way. And, and then when you're in residency as well, we don't do this at Riggs. I don't do any of those as a training director. I'm not doing, empathy checklists and things like that. But certainly when you're in residency, you will probably have training directors who will have set up more of that kind of, markers of development around how are you moving towards expertise as a psychotherapist. That was a very wordy answer, and hopefully it got enough at the question.
No, I think you definitely answered the question and beyond for sure. Thank you. So one of the questions in the chat asks, what about the use of psychotherapy in the acute inpatient setting? I've always been fascinated by the fixed illusions of, for example, being followed by the FBI, etc. Why do patients have these similar associations? Can it be explored through psychotherapy? And thank you for that question, Salim.
So, I think, as I said, I think psychotherapy, Sigmund Freud, I think, made the point that we can never escape psychotherapy because everything that we say to a patient has an effect on the way the patient experiences themselves or understands something. And so basically every word that comes out of our mouth shapes something about the patient's experience of us or of themselves. So so Freud makes the point, we're doing psychotherapy all the time without ever intending to do so. And he says, but shouldn't we then really try to obtain some command of this factor and be thoughtful about how we speak to our patients in order to have a more beneficial psychotherapeutic effect? Because, again, you can say things to patients which are not particularly helpful to their self-concept, their self-esteem. My training director, this is maybe an aside, but one of my training director when I trained once said that a good therapist keeps the patient away from a bad therapist while they get better. And I think he's highlighting that if you're not respectful, mindful, sensitive, growth promoting in your approach, you may actually get in patients' ways. So, oh gosh, you're gonna have to ask the question again. I even just got myself lost.
No worries. The question is about the use of psychotherapy in acute inpatient.
Oh, acute. So you're doing psychotherapy, I think, all the time. Now, it is the case that delusions, for example, are notoriously recalcitrant to medications, to psychodynamic interpretations. They're very, very, very deep-seated, and oftentimes, actually, I think having a psychodynamic framework is maybe more helpful to us even than the patient. Oh, well, let me give you an example from somebody that came to Riggs. So a patient comes to Riggs. She's in her mid to late 40s. She's psychotic, delusional, hallucinating, been on, has not been able to tolerate a whole host of medications, and nothing has really worked. And so she comes to Riggs because of this. And basically her parents were aging and we're starting to get worried about that they weren't going to be able to take care of her forever. And so we're looking to see if maybe something would help. She comes in on an old antipsychotic medication. She's on Prolixin, which you maybe have never even heard of. And I think, this really, she should be on a second generation antipsychotic. But she has this belief that if she takes one of these newer medications, she will become depressed and kill herself. Okay. So you can imagine so I say, well, really, you should try this. And, you haven't tried this, maybe you should try, I'm just cajoling. And this is when I'm a fellow. I think I might've been a little, when I was a trainee, I might have had a little more distance now, but you know, it just kept cajoling until she would be ready to try. And then you could imagine what would happen, right? If she was convinced that this was going to kill her, right? Her anxiety spun out, her psychosis within hours was shooting through the roof, not because you know the Risperdal or Abilify or whatever it was. Actually, in this case, it was Zyprexa or Seroquel, not because it made her more psychotic, but she was just so anxious that the whole thing spun out, and I had to stop it. And you know, we went through this multiple times, and I was feeling increasingly thwarted, and you know, and more frustrated and not knowing what to do. And so I was getting filled up with you know, some harder to bear feelings. And eventually, we put the story together. So this is a woman who, in her early 20s, started showing her first signs of psychosis, but also in her early 20s, got pregnant, had a child, moved in with her parents, who were very supportive parents, and competently raised her son, fairly competently, with a lot of support. And when her son was 6 years old, he developed a glioblastoma and died after almost a year. So does anybody want to guess? Does anybody want to guess what the most common hallucination was? This is low-hanging fruit.
The child.
Yes, absolutely. The hallucinated voice of her dead child. And among her delusions were two of the more prominent ones. One was that she could cure AIDS and various deadly diseases. And the other delusion was that she held the secret for raising the dead. Okay, so you can understand what I'm up against here, right? How puny what I have to offer her is compared to what her psychosis is offering her in this moment. Now you know, the complicated thing is, you know, psychosis is such an awful thing. And primarily, I don't think because of the hallucinations and delusions, but because it is such a lonely experience, right? And of course, that ends up for somebody like this, it's a kind of a vicious cycle where she's so lonely. So of course, she needs the hallucinated voice of her dead child. And you know, one of the other things that started to get clear, of course, was also like this what seemed to be a delusional belief that this antipsychotic was going to make her depressed and she'd kill herself, was actually deeply true in a psychotic sense, right? Which was, she understood that if this medication works, that her child would be dead and would be dead forever. And the grief of that would kill her, right? Now, in this case, having that interpretation, yeah, but this is not an interpretation I'm like going to say to the patient. She's going to be like, oh, okay, you know, now I'm good. You know, what it did for me was it let me empathically appreciate what she was up against. I felt less frustrated. I got more off her back. She did some grief work in her psychotherapy because I was just a prescriber in this case. And after about 6 or 8 months, she had grieved enough in her psychotherapy that she was able to go in Clozaril to tolerate it. She became, you know, much more focused, much more relatable. She was able to develop friends for the first time in a very long time, when, you know, basically her whole relational world had been her parents before that. The delusions pretty much cleared up, and this may have been actually a best case scenario for her. She never did lose the hallucinated voice of her son. You know, and again, I think this speaks to like what we think of, what are our goals? Are our goals to get rid of symptoms, or our goals to put, you know, to get our patients where they're trying to get? And for her, I think that may have been a best case scenario where she actually still got to hear her son. So in that case, I think inpatient in those settings, seldom are you going to be able to use psychodynamic understandings to affect big changes in your patients' lives, but you will be able to use them to be more empathic with what our patients are up against. And we know that helps treatments, right? The more empathic you are, the more likely patients are. There was actually just an interesting study. It's not with patients, but there's just a study that came out last week where they did a 30-minute empathy training for parole officers. 30-minute empathy training, 17% reduction in recidivism 10 months later, right? So anything that we can do that helps us maintain a more empathic position in relation to our patients has the potential to help them, get better further down the road.
Wow, that's a lot to take in and process. Thank you so much for sharing that experience. And yeah, sorry, I'm still processing what I just heard. So not to move on too quickly to the next topic. So right now we're supposed to practically be on break. But the whole point was to have a Q&A with you or break, whichever people want to participate, they could. So obviously we're just going to keep going with the session, but I have to give you an 11-minute warning for the end of the session. So I apologize for that. So there's another question from the chat, and the question says, today we have a daily conversation about racism. Do you think that racism should be addressed in psychiatry rather than politics, or should they be addressed together?
Actually, I'm not sure I understand the question or the distinction that's being made between psychiatry and politics. Maybe the person asked the question.
Yeah, if the person wants to ask it, vocally, they could, or they can also rewrite the question and I can ask it again if that's okay.
Is somebody typing?
I'm not sure. There's no way to know if someone is typing on Zoom,
Okay.
Unfortunately.
Okay, well, let me see if I can look at the question. The active FMA to avoid. Okay.
So I can copy and paste it in the chat. I just wanted to preserve anonymity just in case Bishan wished to. Sorry, the person I'm still processing. I'm sorry. It just in case that person wished to stay anonymous. So I just copied and pasted it into the chat, and then and if the person who asked it wishes to re-ask it, please feel free to do so.
Okay. Okay. So I think, the obvious answer is it should be addressed everywhere for starters, right? So, I don't know how much of this came up in your thing today, but certainly the American Psychiatric Association and actually the American Psychoanalytic Association are all, in the last year or two, much more highly attuned to implicit biases, the whiteness of those, or historical whiteness of those organizations, and all of that. And so, this is the kind of thing that has to be addressed at obviously. It's like, every single level, from the broader political level to the level of medical politics and psychiatric politics to the consulting room. And then I think it goes the other way as well, because I think there's a lot, and if you are interested, it might not be that hard for me to come up with some, somewhere in a recent email, some papers addressing the relationship between the unconscious and and racism, and actually the move from unconscious to conscious. So there's also that there are things that psychiatry, I think, and particularly psychodynamic psychotherapy or psychoanalysis has to offer to this discussion around the ways that minds work and around the kinds of things that happen in our minds outside of our awareness before we even know what happened. And so I think obviously it's a change has got to come from like every single direction on this kind of thing.
Thank you.
Hopefully that answered the question.
Yes, and we'd absolutely be interested in those papers if you do have access to them. So maybe what I can do is when I'm uploading the conference, I can also attach the papers too, if that's okay.
Yeah, okay, I can email it to you. I can email it to you right after this.
Okay, thank you very much.
It's on my other computer over there. So
That's convenient. So again, there was also one last question from the chat, and we'll see if we have time to take another one. But the question essentially asks, so nowadays there's not a lot of focus on psychotherapy, let alone psychodynamic psychotherapy in residency training. How would you advise people interested in psychotherapy in approaching programs and asking the question if the program offers a sufficient training in therapy?
I have a very easy answer to that one. So first of all, there are the Psychiatry RRC, which creates the rules for what psychiatry residencies have to do, has specified there are 3 psychotherapy competencies that have to be taught. So every resident has to be taught a psychodynamic psychotherapy, cognitive behavioral therapy, and supportive psychotherapy. So you will get that in residency. And most residencies will tell you they're excellent at teaching it. Or maybe almost all will tell you that. No, that may not be true. There will be some programs in the middle of the country who say, we're really biologic and we're really proud of that. And we're science-based. But most residencies will want you to know that they respect psychodynamic training and will give you good training. For those of you that are heading towards, for those of you that are PG or MS3s, rising MS4s, there's going to be a psychotherapy fair. I don't know if the MS4s went to that, but we just created. The last thing I did as the director of, or the leader of the psychotherapy caucus, was to work with PsychSIGN to actually create a psychotherapy fair. So there's a big thing with 200 and some odd or more students, and about 40 programs that self-identify as being particularly strong in psychotherapy. We've developed, one of the more helpful things was I think we developed a list of questions that really point towards the strengths of programs. So it gives you a way, and I could probably send those questions to you as well. These are the kind of questions you can ask, at what year do you first get your first psychotherapy case? Is it your PGY2 or PGY3? How much time in didactics? Do they give you time and support for your own psychodynamic treatment? Who teaches psychodynamics? Is it psychologists and social workers, or is it psychiatrists and role models? There's a lot of questions like that I think you can help you figure out which programs are really stronger in psychotherapy than other programs.
Thank you. Yeah, that would definitely be helpful, especially in terms of like asking questions and figuring that out. And it's very good to know that 40 programs, self-identified as having that as a strength, because it's really cool to see a psychiatry, or traditional biomedical psychiatry, and psychotherapy at work together. So we do have around 3 minutes left. So if anyone has any last minute questions, please feel free to unmute yourself and ask, or dropping them in the chat.
If there aren't questions, maybe one point I would want to make is about the evidence base for psychodynamic treatment. Here's another, let me find another study for you. Hold on a second. There's a great paper. Is this now? Okay. Yes, okay. So let me pull this up for a second. So Jonathan Shedler wrote a nice paper here where he was really trying to push back against some of the biases against psychodynamic treatment. And it was a paper that maybe 10 years ago got some attention. But one of the really interesting things that he did was he looked at effect sizes in our research. And, obviously, an effect size by convention, 0.2 is a pretty small effect size, 0.5 is moderate, and greater than 0.8 would be considered a large effect size. And it turns out that the average effect sizes of all psychotherapies falls in the 0.62 to 0.85 range. Now, this is a little bit of comparing apples and oranges, as people who are critiquing this will remind you. But when you look at drug studies, like especially particularly antidepressants, you get effect sizes of about 0.3. And according to Joanna Moncrief and her group, when you use active placebo, so something where somebody feels different, so they know they got a substance, as opposed to the what happens in a lot of placebo trials is you feel different, so you got the drug, and so that boosts the placebo effect, right? So when you use active placebos, the effect sizes in those studies is as low as 0.17. And as the speaker before me noted, that there are three kinds of lies, and so people can debate those numbers in all sorts of ways, but turns out that for psychodynamic treatment, when you get, especially when the longer it is, the bigger the results. You can get effect sizes of 2.21 for somatic symptoms, 1.51 for general symptoms, 1.35 for anxiety, and 0.98 for depression. So these are substantially larger than effect sizes for medications. And again, these are things that are synergistic, so they can work together. And one last interesting thing before we say goodbye is the other interesting thing about psychodynamics is with most treatments, when you stop the treatment, the effect starts to drop off. And with psychodynamic treatments, you can see from these things that when you stop treatment, patients continue to gain for about a year before it plateaus. So these studies show like it's 0.97 for general symptoms at the end of treatment, but 1.51 at 9 months follow-up. And so psychodynamic treatments, what happens is patients become their own analysts or their own therapists in a way. And so, they continue to improve for at least a year before plateauing. So, and on that, I guess now I am at 2:20. So thank you very much. I will see if I can get those papers to you, Chaden.
Awesome. Thank you so much. And thank you for blowing our minds. Seriously, that was amazing. And it was a very insightful presentation. We really appreciate it. Thank you so
You're
much.
very welcome, all of you. Okay, take care.
Enjoy the rest of your weekend. Okay, so we're currently at time for this session. We have our next session at 2:20, and it's going to be with Dr. Wasser. I do not see him in the presentation, so I'm going to be giving him a quick call, and then I'll get back to everyone. Hello, Dr. Wasser, how are you? I believe you're muted. I'm sorry. Dr. Wasser, can you hear me? I believe your mic is muted currently. It's showing the red.
There we go. Is that better?
That's perfect. Thank you very much.
No problem.
You might have a missed call from me, so I apologize if I called you. I just wanted to make sure. First of all, thank you so much for logging in on a Saturday. We really appreciate that.
Sure, happy to.
So Dr. Wasser, he's our next speaker. He obtained his undergraduate degree in psychology at Wesleyan University and completed medical school at the University of Connecticut School of Medicine. He completed all his psychiatry training at Yale, first starting with his psychiatry residency, and then followed by fellowships in both forensic and public psychiatry. He's currently an assistant professor of psychiatry in the Department of Psychiatry, with faculty appointments in both the public psychiatry and the law and psychiatry divisions. He is also one of the associate program directors at the Yale Psychiatry Residency Program, and he works clinically and administratively at the Chief Medical Office of Whiting Forensic Hospital, which is Connecticut's only state-operated forensic hospital. Additionally, Dr. Wasser is the president-elect of AAPAL, which is the American Association of Psychiatric Leadership, and he's coming here today after a trip and sacrificing his time to talk to us today about psychiatry and leadership and how to engage in leadership as an early career psychiatrist. Thank you so much, Dr. Wasser.
Sure, I'm happy to be here. Sorry about the technical stuff getting on.
Yeah, I know the Zoom application has been giving everyone trouble with the updates. So
Okay.
I apologize for that inconvenience. So just to start off, would you mind telling us what interested you in the topic of leadership in psychiatry so early on in your career?
Sure. So, hi, good afternoon, everybody. So, I think that I had experiences in medical school that gave me a sense that I might be interested in doing leadership type positions. I was the vice president in our medical school student government, and had other kinds of experiences organizing activities and committees and things like that. And then I think as I went through my psychiatry residency, I had opportunities to be in charge of either committees or there's sort of not exactly a student government, but a residents association. And I was selected one of the co-presidents of that. And so there were other opportunities I guess I didn't realize it quite at the time, but I practice and hone leadership skills. And then the more I moved through my training, I realized that leadership within psychiatry, one, is really important because as psychiatrists, we need to be leaders in the field of mental health, but also in some ways it is its own skill set. Not everyone who enters psychiatry wants to be a leader. Some people have different interests, want to just do clinical work. But I thought of it as something that I needed to hone, and also that as psychiatrists or future psychiatrists, you have a skill set that really makes you adept at being a leader. The idea of listening, communicating, thinking about sort of themes about what's going on in dynamics beyond just what's going on in your one-to-one interaction between a person, thinking about systems. So all of those things are unique abilities of psychiatrists that I think make them adept at being leaders. And so it was sort of the combination of those two ideas that made me feel like it was important. And then I sort of strategically started to pursue opportunities to learn more about leadership so that I would have those opportunities.
So thank you so much for this inherent great segue, which is you mentioned about strategically seeking out those opportunities. So the follow-up question would be, what is some advice you would have for medical students who are interested in leadership, and how would you advise them on jumpstarting their career in psychiatric leadership?
So what I would say is, I think the first thing to do is to think about what are the skills of being a leader, and then what are the opportunities you have to practice those skills in other venues. So I talked about some of them. So obviously, we're not going to jump from being a medical student to being a resident to running a clinic or being in charge of a facility, or, it's important to have experience, but at the same time, you can gain practice and skills and also demonstrate your ability to organize. And if you think about it, I mean, leadership at its basic core is kind of organizing and galvanizing a group of people toward a common mission, a common goal, a common end point. And so you want to look for opportunities to do that. So on a very small scale, that would be committee leadership or other, organizing activities, demonstrating that you have a track record of being able to successfully bring a group of people together to accomplish some goal. As you move through residency, there are dedicated opportunities to learn more about certain kinds of leadership. So the American Psychiatric Association has different fellowships that are available. They have a diversity fellowship, they have a minority health fellowship, they have substance abuse fellowships, child fellowship, public psychiatry fellowship, a leadership fellowship. So there are all sorts of different opportunities to learn about essentially organized psychiatry, which is one venue to learn about leadership within psychiatry. And then there are more sort of codified things as you get further into your residency training. So being a chief resident, and there are, every residency program handles chief residency differently. So most programs have some version of a kind of program-wide chief or someone who kind of oversees the whole process. Some residencies divide it up based on having an outpatient chief and an inpatient chief, or having a chief at each clinical site. If it's a multi-site institution, and sometimes it's just being the chief of a unit, or being the chief of diversity, or being the chief of education. So there are different opportunities, but all of those will give you a chance to practice those skills depending on what your particular interest and skill set are. And then there are certainly organizations that are interested in leadership. So Chaden mentioned that I'm the president-elect for what the acronym is AAPAL, the American Association of Psychiatric Administration and Leadership. So we're certainly a group of psychiatrists who have different types and degrees of leadership roles within organizations, and we come together to think about leadership and leadership education and how do we train the next generation of leaders. The other opportunities potentially are either through advanced training or fellowship. So you certainly can think about whether you want to get some kind of master's degree if you don't have one already. A master's in public health, a master's in business administration. There's actually something called a MMM, a master's in medical management, that's offered by Carnegie Mellon and a couple other programs. So those are all additional opportunities to learn very clear and get a degree in sort of advanced leadership skills. And then there also are fellowships that are dedicated to typically public psychiatry, public administrative community psychiatry. And those vary. Some are really focused on kind of community-based work and with less of a focus on leadership, but most of them have some focus at least on administration and leadership. So that's another opportunity. And because it's not an ACGME accredited fellowship, you can do it. Sometimes people can do it as their PGY 4 year, or they can do it after completing residency, and you can actually be paid a little bit higher than a PGY 5 because it doesn't have to slot into the exact salary structure as for accredited fellowships. So those are some of the opportunities.
Thank you for letting us know about all these opportunities and organizing them in such a concise manner. So a lot of times in leadership, it's extremely important for people to have a mentor. So one of the questions that a lot of people ask is, how does a medical student approach someone they admire to ask them to be their mentor? And how would you approach the process of asking for a mentor in general?
That's a really great question. And I think you guys are identifying, first of all, I just want to say, I know Chaden is moderating and organizing, but I really want to encourage people, if you have questions, feel free to unmute yourself, interrupt me, ask questions. I'd like this to be as informal as possible. And I'm interested in being helpful. And I think mentorship is really key. Certainly mentorship has been really important in my development. But I've had kind of hit and misses. So when I was a resident, I knew early on I was interested in forensic psychiatry. And so I reached out to the leadership of the forensic fellowship at my residency. I let them know in my PGY 1 year, like, hey, I'm interested in forensics. What can I do to learn about forensics, get more involved, demonstrate my interest? And the head of the fellowship kind of connected me to a bunch of different people. I will say pretty much none of those connections actually worked out in the long run. And then I thought I found somebody through a slightly different process who was part of the forensics department. He seemed like a great mentor, had a trajectory I was really interested in his career. We started working on a project together. And then like a year into it, he left and moved to Colorado. And so then again, I was like, oh, what do I do? So I guess I will say sometimes the search for mentorship is not like clean and clear cut. Sometimes it has to be an iterative process until you find a good match. But with that said, to come back to the question of how do you do it? So I think one thing to think about, one, generally, if you're interested in a topic that someone else has already made their career, they're going to be interested in talking to you about it. For the most part, people, this is just sort of a general rule of thumb, people like talking about themselves. And so if you reach out to somebody and say, hey, I'm interested in the work you do, it seems captivating and wonderful and blah, 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 I'd like to hear more about it. Generally, that's going to make somebody feel good about themselves, and they're going to want to talk to you about their career and the things they do. The other thing is sort of in a more practical way to think about it as a quid pro quo. So what do you have to offer that person that is going to make them interested in mentoring you and helping you learn new skills or develop some projects that you can add to your CV and things like that? So I know when I was a little bit when I was a med student, but then certainly when I was a resident and I did reach out to people, it was usually with, hey, I'm interested in being involved in a project or writing a paper or doing something to develop my skill set. Do you have anything that you have going on that I could contribute to? And you being willing to do, I wouldn't call it scut work, but being willing to do work that is less stimulating to them, but for you is really interesting and important and allows you to gain some knowledge and experience, but also providing a valuable service for them is really, that's kind of a win-win. And I know now that I'm a faculty member, I love that. I love when residents reach out to me and say, hey, I'm really interested in doing a project. Do you have anything going? And sometimes right in that moment, I'm like, yeah, I have these 3 things and I really don't want to do the lit review on this. So if you want to do that and write something, and like, that's great. And then you get to be a co-author on a paper, you begin to form a relationship. And sometimes in the moment they reach out, I don't. I had this actually recently where a young woman who's a PGY1 at our program had a legal background, was interested in forensics or learning more about it. She reached out at a time that I didn't have something going on, but I just kind of kept her in mind. And then a few months later, I did have a project where, again, there was sort of a big search that needed to be done and written up. And I thought, well, if you're interested in doing that, it saves me many hours of time. So I think those are the kinds of things that you guys have a lot to offer. And obviously, it's going to vary. So when you're PGY1s, you're not going to have a lot of time. You're going to be doing medicine and neurology and inpatient rotations. And so you're not going to have ample time to do that kind of work, but you're still going to probably have opportunities where you can begin to form those relationships. So, at some point you can reach out to people by email. The other thing to do is, if you're not sure who to reach out to, depending on what your particular interest is, I would start with your residency leadership and just say, hey, I'm really interested in topic X. Who around here does stuff in topic X or knows people in topic X? And have them help you make the connection. That's another thing that can be helpful. So often, I've done that sometimes too, particularly now that I'm in a residency role, that I'll talk to people who I supervise and they will express an interest in a particular area and want to know who's the person to talk to. And I will do sort of an email introduction for them and say, hey, Joe Smith, this particular resident seems wonderful, they're interested in you or whatever. And that can help be the gateway for that person, particularly if you don't feel comfortable sort of cold calling or cold emailing somebody.
Thank you. These are, definitely very helpful tips on how to approach mentorship. And please, everyone, feel free to either unmute yourself, ask a question, or include in the chat, or send it directly to me if you want me to ask it anonymously. So one question that we always have on our mind is what makes for a good mentor-mentee relationship, and what in terms of on both sides, both the mentor and the mentee side. And I guess you having went through training, being the mentee and now being a mentor, how would you define like a good dynamic relationship and a good long-lasting relationship?
That's a great question. So I think one thing, I mean, starting with the basic building blocks, I think having common areas of interest is a great place to start. I think then working with some of the things I already mentioned, just in terms of a mutually beneficial relationship where you're able to find ways that you're helpful. But I would say on the mentee side, you want to find people who are genuinely interested in you and your career, absent their own interest. I mean, despite what I just said, you want to be helpful to them. That's a good way to get things started. But you want to have people who are going to be willing to make time for you, who are going to look out for you, be willing to either write letters of reference on your behalf or connect you to the right people. If someone early on in the relationship isn't making time for you, is making it very hard, or only seems interested in talking to you if it's for their own benefit, that's not the beginnings of a good mentor-mentee relationship. And I think I would either steer clear or sort of slowly fade into the background of those relationships and look for other opportunities or other connections. I think as a mentor, what I'm interested in, or I think what I think makes a good mentee, one is someone who's interested in being helpful. That definitely helps. But I think also someone who, maybe the flip side of it is, it can be sort of a turnoff if you feel that somebody is only interested in talking to you, working with you, if it's solely for their kind of self-interested benefit. So if it feels like everything you're talking to them about is just like them trying to use you in some way to achieve some other goal, that's not a good feeling as a mentor. I think you want someone who you feel like you have a connection with. It's not quite the same as, I mean, I think it's not quite the same, but you can analogize it a little bit to like a therapeutic relationship, that, you know, you need to have a connection with that person the same way you want to build rapport and have a therapeutic alliance if you yourself are in treatment or if you are a treatment provider for somebody in psychiatry. And you need to have that. It doesn't always, you know, you don't click right away with everybody, but if you don't build sort of a sense of rapport and comfort and ability to speak to somebody and feel like they're looking out for your interests and vice versa, it's probably not going to be a good long-term relationship.
That, you know, that actually makes a lot of sense. And, you know, thank you for offering the mentor perspective on that, because obviously we don't know what it's like to be on the other side. So again, everyone feel free to put questions in the chat, but I guess one of the question is, in terms of research, how can someone make their interests known in a concise manner when they're not really sure what aspect of research they want to get out of a mentor-mentee relationship?
So if you're not sure exactly what you want to do, I would think of considering yourself as sort of like an opportunity window shopper, and, you know, try to set up meetings with multiple people, and but also be very upfront about what you sort of, the degree of your commitment or where you are. So I think to reach out to a handful of people, you know, whether somebody in addiction, somebody in child, somebody in Jerry, and say, you know, hey, I'm interested in getting involved in a project. I'm still developing what my specific set of interests are. So I would be, if you have opportunities, I'd really like to hear about them, and then let them talk. And then, you know, at the end, I think it would be very fair to say, you know, thank you so much for meeting with me. I have a couple other meetings with other people set up. As you know, as I said, I'm still developing my interests. And I think some of what you've said sounds really appealing, but I wouldn't want to make a commitment to you unless I'm sure I could follow through with it. Would it be okay if I got back to you in a week or two once I've had time to think about it and I'm sure about what I can or cannot commit to? I think something to that extent would be totally fair. Because at the same time, I think it's hard when you're in the sort of in the power dynamic. It's hard to be in the medical student or the early resident role, because the faculty person seemingly has more power in the relationship. And I know I have certainly felt, whether it's internal or external pressure to say yes or agree to do things or try to make people feel good. And so I will sort of acquiesce to doing things and then later be like, why the heck did I do that? And I mean, I remember in particular being a resident, and I was really trying hard to find a project, and I ended up agreeing to do, it was a even though I was interested in forensics, I somehow ended up kind of glomming on to the person who was in charge of the CL fellowship at Yale New Haven Hospital. We were doing some kind of he kind of convinced me it was forensic E because there was something about capacity assessments involved, and we were going to look at suicidal patients in the hospital and whether something was done. And I was kind of going along on this for months and months, and at a certain point, I just thought like, God, I just really don't want to do this, but I'm terrified to tell this person I don't want to do this anymore. And so I spoke to some peers and somebody else, and finally I got up the courage just to send an email and say, I'm sorry, but I think at this time I have other responsibilities are going to preclude me from participating further or whatever. And I felt such a big sense of relief when he wrote back and said, okay, no problem, thanks. Like it was such a not big deal to him, but I know to me in that moment, I was terrified that I was like ruining my career. So I think that's important to be clear about, and that this is not the best example of how to do this because I just said I agreed to do something for a long time and didn't set good boundaries, but maybe it's an example that you can learn from that. I think it probably is less of a big deal to that other person as it is than it feels like it is to you. And the more clear you can be about your boundaries and what you're able to do and not able to do, you set yourself up for a better working relationship, because I think over promising or feeling pressured into commitments that you're not really comfortable with will ultimately increase the risk that you have some kind of uncomfortable interaction in the future, or you just get stuck doing a bunch of work you're not really that passionate about. And as you go through training, you only have so much time to work on these kinds of things. So you want to use your time as effectively and efficiently as possible.
Thank you. And I feel like everyone at some point have definitely been a victim of overcommitting. And then we all have to learn how to do those project breakups at some point in our life. So thank you, for offering, a fresh perspective on how to do and how to approach it properly. So one question was, a couple questions ago, you mentioned a letter of recommendation. How would you advise students or residents to ask for a letter of recommendation? What sort of, jargon or verbiage are you would you most recommend people use?
So whenever I've asked for letters, or when people ask me this question, I think I think probably the most comfortable but straightforward way of phrasing the question is to ask if somebody would, explain what the opportunity is, and ask if they would be comfortable writing you a strong letter of recommendation. Because I think if someone isn't comfort is a great place to ask around, to set up difficult questions, because everyone can feel comfortable or uncomfortable with things without it having to be, I don't like you, I don't think you're good. It doesn't have to be, it's just about, either depending on whose perspective, your comfort or their comfort. But I think that frames it in a way that also you don't have to wonder about what kind of a letter they're going to write you, because the other piece is you don't want to ask someone for just, can you please write me a letter of recommendation, without having any idea what they're going to put in that letter. So if you just ask for a letter, they might say yes, and it may be very lukewarm. So framing the question that way, I think, makes it very clear what you're hoping they're going to do, and then they can be as honest as they feel they're able to about their comfort doing that. And then that way, if they agree to it, you at least have a pretty good sense that they're going to write something good. The other piece is, it's particularly the further along you go, not when you're at this stage when you guys are going to be applying for residencies, this would not be appropriate. People are not, but as you move further along, it's not uncommon that people will ask you to write a draft of the letter yourself. So I know that as I move through training, and particularly into my early career, and I've had to ask for these kinds of things, it's pretty common that they say, can you write a draft of the letter and send it to me? And then I will work off of your draft as essentially a template. And part of it is that there's two pieces to that. I think one, they don't know you as well as you know you, and so they're probably wanting to make sure that the things that you want to be highlighted are being highlighted, and you probably understand the particular award or opportunity better than they do. The other reason, just quite honestly, is it's a fair amount of work to write a letter of recommendation, having written lots of letters of recommendation. And so if someone can, it's always easier to edit somebody else's work than it is to start something from scratch. And so I let you all know this because I think it's a poorly kept secret that people all learn at some point in the process. And it's also, there's nothing wrong with it. It sounds kind of deceptive or not on the up and up, but it's kind of the way the world works. And it's also, it's not as if they're asking you to just write the letter and then they, hopefully, if they sent in just the letter that you wrote, that would be not good. That would not be right. But for someone to draft something and then for them to edit it and put it in their own words and make sure they're comfortable with the language in it, that is pretty commonly accepted practice.
I see. And, thank you for letting us know again for the behind the scenes, because, yeah, we really don't get exposed to these sort of things like so early on in our career. So I think this is all for the pre-written questions. So we're just gonna open up the chat, and if you want, please feel free to unmute yourself and ask questions, or again, writing them in the chat as well.
I guess going off the topic of writing like a letter of recommendation, I was wondering, in your opinion, like what are the components that help convey that, like if you were an AdCom, that this is a strong letter compared to all the other letters of recommendations they see from all the other students?
So there are a couple of things. So I think one, it's always more important to get a letter from somebody who knows you well, who may not have as high a position than it is to get the position from the highest ranking person at the institution or who's nationally known for X or Y or Z reason if they don't really know you. So letters from really important people only matter if they really know you. So I will say, reading the letters that come in, if I see people either I personally know or, so I guess that's actually one other thing to know is if the person you're asking has personal connections to a particular institution that you're really interested in, that does help. So, if some faculty member that I know for whatever reason is at Michigan and then they write a letter for some person who's applying for a residency, I put more stock in what they say because I know them, I know the caliber of their work. And but the most important thing is that the person really knows you. So the second thing that's the different things that people can include in letters that help differentiate them are oftentimes you'll see in letters something like this person is in the top 10%, 5%, 1% of all medical students I've ever worked with before. That's sort of a vague, it's not a hard and fast metric, but it's meaningful. So if somebody has worked with thousands of students over the course of their very long career and they say you're in the top 10% of all the students that they've ever worked with, that's really meaningful, versus if they're a very new person and they say you're in the top 10% of all students, but I've only worked with 10 students or so, like that's not quite the same. The other thing, again, I think is a letter to me, I don't need a letter to recapitulate the things that you've done because those things are going to be on your CV or your resume, and I don't need to read them twice. What I want to hear about is the stuff that's not in your CV. So what are you like to work with as a person? What kind of a colleague are you? What kind of a clinician are you? Or what was their experience like working with you on a project? So, but there might be some line on your CV that says, you were the research assistant on blah, blah, blah project. Having it be rewritten, it's not as important to me to see you were there. I worked with them. The person has to provide the context to say, I worked with them when they were a research assistant working under me on blah, blah, blah project. But what I really care about was when you were assigned tasks, you did them responsibly, on time, you were happy to do them, you were curious about the work you were doing, you asked inquisitive questions. That's the stuff that is kind of the richness of a letter that's much more interesting than just someone who rewrites your CV and says, they're great, please take them.
Thank you.
So I just got a question in the chat. and it says it will be comfortable asking the person if I can write a template as an example in case of international students who don't speak English. So how should I address it in terms of offering a template?
So what I would say is I think when you ask for the letter of recommendation, when you ask if they're comfortable writing you a strong letter of recommendation, you can also include in there the offer to write a draft. So that's also, there's nothing wrong with that in many settings to say, would you be comfortable writing me a strong letter? If so, I really appreciate it. I recognize that's a significant, expenditure of time and energy on your part. If it would be helpful, I would be very comfortable drafting or writing a draft of the letter for you. Or sometimes I've also offered or had people offer to sort of give me an outline of the things that they think would really be important to highlight in the letter. So again, those are all fine. I think it's all about framing and trying to be careful, and this may be hard as if English is not your first language, but being careful in the way that you use language to make offers, because saying things very directly can sometimes be misperceived, and so trying to put some softness around it can really help. The other thing is I would generally recommend, even though it's more efficient in this digital age to send send an email asking for a letter, I would try to ask verbally, whether that's in person, through a Zoom, through a phone call, because again, I think there's an opportunity for nuance to be lost in just getting an email. And I think it's nicer to have somebody ask you. The other thing you want to make sure you include is what's the time frame. So, and you don't want to leave somebody no time. So if someone comes to me and says, hey, can you write me a letter? It's due in 2 weeks. I'm going to be a little annoyed. I might agree to do it, but I'm not going to be thrilled about it, and they're not going to get my best effort. So I would say ideally, in a really, really ideal world, you want to give somebody like 2 months of notice at least. I would think 1 month is kind of the bare minimum. So those would be some of the things I think about.
Thank you. And, thank you for letting us know about the timeline. Definitely the 1 month versus 2 months versus 2 weeks, I guess, timeline, because that's important when we're asking those questions. Yeah, so I think we're up to date with the chat. Again, please feel free to unmute yourself if you have any questions. All right. In the meantime, do you have some last minute words for people who are interested in being involved in leadership and I guess what sort of cool projects they can focus on, especially now, I guess in this COVID world and psychiatry?
So I think my final thoughts would be, if you're someone who's interested in leadership in psychiatry, that's awesome. We need more people who are interested in being leaders in psychiatry. The world of mental health is I think, so I don't want to speak out of turn about colleagues in other fields, whether that's social work or psychology or whatever. I think they are wonderful and they are important colleagues to have and there's a lot of work to be done. But I also, from a very biased and self-interested perspective, feel like psychiatrists need to be the leaders in mental health. And so we need more young people like yourselves who are interested in coming into the field and representing the span of disciplines for which psychiatry needs leaders. Again, whether your interest is in public sector work, addiction, geriatrics, child and adolescent, we need it all. There's a lot of work to be done. I think as you think about going into residency, the most important thing is that whatever you're doing, it's something that you're passionate about, because it's really just building up things to put on a CV is really not nearly as compelling if the person doesn't feel passionate about it. And the other thing I'd say, certainly from doing lots of residency interviews and different things, is that we don't, like at our program, we're very much interested in people who are going to be leaders. We don't think about it as you've got to be a leader in this. So it's got to be research or it's got to be addiction. We're interested in people who are starting to cultivate a niche for themselves. And obviously, when you're early on and in your guys' stage, that niche is going to be, I'm trying to find the camera here, it's going to be pretty broad. And then as you go further along, you slowly start to work it smaller to whatever your particular area of interest is. The other thing I'd say is if any of you are interested, I would really advocate that you get involved with AAPAL. I think it's a growing organization. It started actually back, I think, in the 70s and was at one point very large and well established. And into the sort of 90s and 2000s, it kind of fell off the map. And now over the last 5 to 10 years, we've got a group of probably 20 to 30 of us who are very passionate about the work, who are trying to get more involved and really create it as an educational and sort of think tank resource for people like yourselves who are interested in leadership. Chaden has been a wonderful contributor to that and really helped us develop our website and do some conferences and other work. So the more of you who are interested in doing that, the better. And I'd be happy to speak to you guys offline at any point, whether about AAPAL certainly, or really any other areas of interest you have. I'd be happy to do that. So feel free. My email is just my first name, tobias.wasser@yale.edu, and you're welcome to reach out to me at any time.
And another thing, just to plug AAPAL, I promise this isn't like a commercial, but it does offer also free membership for students and trainees. So we don't have to pay for the dues, and it has a lot of cool and very interesting articles on the website as well that are very fascinating. So I'll be also putting in the website in the chat. And yeah, as we're concluding this session, thank you very much, Dr. Wasser, for carving out this time during your weekend to come talk to us about leadership and networking. We really appreciate it.
No problem. I'm happy to do it. And again, anybody is welcome to reach out to me at any point after the fact if I could be helpful.
Have a good one.
Thank you guys. Bye.
Goodbye. Okay, I'm just gonna link the website here. And maybe if I can find Dr. Wasser's email address as well, that way everyone can have access to it. But in the meantime, since we have like 30 seconds to spare before our match panel, which is very exciting, please feel free to unmute and say whatever is on your mind. And yes, of course. Sorry, I'll be sharing all the documents that Dr. Mintz talked about in terms of the papers, as well as the fair that he mentioned from last year. I think Sarin, yeah, she's here. So yes, I think PsychSIGN took care of that, and I think I have access to the resources that they used about the fair from last year. So I'll be sharing those also. So we've made it. This is the last. This is the last and arguably most exciting session for the conference. I will be stopping the recording just so that our panelists can speak more freely about their experiences. So I apologize. This portion of the conference will not be recorded.